umbilical, which was confirmed by micturating cystoretrography. He had excision and repair of the bladder via transverse umbilical incision, and then wound healed satisfactorily. This is the child showing the leakage of urine, and this is intraoperative findings showing the persistent urachus. This is intra-op during the excision, and this is post-op after the excision. For discussion, the exact mechanism of persistent urachus is unclear. Okay. However, the urachus, the theories have been proposed, one of which is the rapid fibrosis of the urachal epithelium. Sure. The pointer is okay. 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 Let me quickly go to make okay. The diagnosis is usually confirmed by micturating cystoretrography, and this outline the structure, the other complications that may arise, such as vesico-ureteric reflux, and then the associated posterior urethral valve. CT and MRI not commonly done. The treatment is usually surgical excision, and open approach is faster, less costly, and has good cosmetic outcomes in children. In conclusion, persistent urachus is a rare congenital anomaly. Surgical excision is the mainstay of treatment, and open approach is comparable with laparoscopic, particularly in children less than 10 years. Thank you very much.
Thank you, Dr. Isiaku. Can we move to the next presenter, please?
Abstract number 7 by Dr. Abdullahi Umar. Dr. Abdullahi Umar. He will be presenting on the prevalence and clinical characteristics of acute coronary syndrome in Aminu Kano Teaching Hospital, Kano.
Hello. Can we have one house, please? Presentation is going on.
Okay, once. Okay.
Okay, you can start, Dr. Garba.
They said they want to put something.
Huh?
Let me finish. Good morning once again. I still remain Dr. Garba, presenting on the prevalence and clinical characteristics of acute coronary syndrome in Aminu Kano Teaching Hospital, Nigeria. Acute coronary syndrome was previously considered rare in Nigeria. However, recent studies showed that the condition is on the rise. There is epidemiological transition to non-communicable disease all over the African countries. There is rising risk factors for ischemic heart disease, which include hypertension, diabetes, dyslipidemia, and other non-typical risk factors. The objective of the study is to determine the prevalence and clinical characteristics of acute coronary syndrome at Aminu Kano Teaching Hospital. The study was a descriptive observational study, and the population involved were adults more than 18 years with acute coronary syndrome, and the study was carried out between July 2013 to January 2014. Data was collected using semi-structured questionnaire, and analysis was done using SPSS versions 18. the admissions and prevalence. Total medical admissions in that duration were 2001. Cardiovascular admissions were 564, while the acute coronary syndrome cases accounted for 55. The prevalence of acute coronary syndrome was 2.8% among medical admissions, while 9.8% among cardiovascular admission, which is very alarming. Okay, the demographics of the patients, majority of them were males, and the mean age was 60.5 plus or minus 12 years, with the age range of 36 to 85 years. Females were older compared to males, and the difference was statistically significant. This is a bar chart showing the age-sex distribution. As we can see, acute coronary syndrome was higher in the age range of 50 to 59. And if we can see, the males were more than females. And then it's only at the age of 60 to 69 where females were more than males. This is a table showing the socio-demographic characteristics of the patients. As we can see, it's only the gender and the pulse rate that was statistically significant between the study participants between males and females. So the risk factors identified were hypertension, which is the commonest, and the least was type 2 diabetes mellitus. The clinical presentation, majority of them presented with ST segment elevation myocardial infarction, and other acute coronary syndrome constituted the remaining 40%.
Take the mic closer.
So in conclusion, acute coronary syndrome is increasingly prevalent in Nigerian population, as initially thought to be less. Risk profiles resemble those in developed countries, as I highlighted. Our recommendations is to enhance acute coronary syndrome awareness, to improve diagnostic and treatment facilities in the country. Thank you for your time and attention.
Thank you, Dr. Garba, who stand for Dr. Umar Abdullahi for the presentation of acute coronary syndrome.
Thank you. Next we'll be taking abstract number 9 to be presented by, abstract number 8 to be presented by Dr. Isiaku Abubakar. He'll be presenting idiopathic scrotal calcinosis, a rare scrotal presentation. Thank you. Number 8.
Good morning once again. I'm Dr. Abubakar Isiaku from FTH Kasena. Okay. I will be presenting idiopathic scrotal carcinosis, a rare scrotal presentation. This is my outline. Idiopathic scrotal carcinosis is defined as deposition of insoluble calcium crystals in the scrotal skin, subcutaneous tissues, and result in the formation of pillar nodules or papules. It is common in blacks and is usually common between the ages of 20 to 40 years. However, it can occur in other ages group, but very rare. It may affect other parts of the body, such as finger, penis, and vulva. And as such, if it affects vulva, it refers to as idiopathic vulvar carcinosis. The main site of affectation is the scrotum, and this is due to large deposition of elastic fiber within the scrotum. Controversy has existed with regard to the etiopathogenesis, but 5 theories have been proposed, as we can see later. The diagnosis is usually confirmed by histological excision of the tissue, and then various treatments exist, but complete surgical excision remains the best option of treatment to prevent recurrence. The aim of these studies is to emphasize the role of excision biopsy in the diagnosis as well as treatment of idiopathic scrotal carcinosis. The case presentation is a 40-year-old male who presented with 8-year history of scrotal swelling, initially small, but gradually increased in size and number. There is associated itching, but no discharge of chalk-like materials. However, no history of trauma, and there was no history of similar problem in the family. Examination revealed multiple hard gray nodules in the anterior as well as posterior scrotal swellings. The largest measured 2 centimeters by 1.5 by 1.5 centimeters, sparing the penis. The available investigation at that time was the serum, calcium, and phosphate, which were all normal. He had excision under subarachnoid block, and histology confirmed the scrotal carcinosis. This is the picture showing, the first one showing the pathology, and then immediately intraoperative after excision. This is during the follow-up. Okay. Scrotal carcinosis was first described by Lewinsky in 1883. The term idiopathic was discovered by Shapiro in 70s. The theories, there are multiple theories with regard to idiopathic scrotal carcinosis, but the commonest one is the dystrophic theory, which believes the existence of epidermal cysts in the degenerated scrotal muscles. Other theories, these are other theories. This is the plain X-ray showing areas of calcification, and then ultrasound showing areas of hypoechoic and hyperechoic, suggestive of that. Serum calcium were usually normal in individuals, and then histology will confirm the diagnosis. Treatment, many treatment options ranging from observation, medical treatment. However, surgical excision is cheap, provides tissue for histology, less recurrence, and better cosmesis. In conclusion, scrotal carcinosis is a rare presentation, and diagnosis is usually confirmed by excision, and diagnosis is usually confirmed by histology, and then surgical excision is the best option of treatment in the sense that it will prevent recurrence in such cases. Thank you very much.
Thank you very much, Dr. Isiaku, for keeping to the time, please. Next presentation.
When we get to the come back. Thank you. Thank you very much. So we'll be taking the next presentation, which is abstract number 9, to be presented by Dr. Dalha. The topic you'll be presenting is the predictive value of placental thickness on ultrasound and the assessment of birth weight among women with singleton pregnancy in the 3rd trimester at Udut, Sokoto.
Good morning all. My name is Dr. Dalha Abubakar, Radiology Department, Parallel Teaching Hospital, Katsina. The topic I'm going to present is the predictive value of placenta thickness on ultrasound in the assessment of birth weight among women with singleton pregnancy in the 3rd trimester at Udut, Sokoto. The placenta is the main organ that provides...
Take the mic closer.
No. This one. The placenta is the main organ that provides the embryo with nutrients, oxygen, and hormones. It represents the crucial connection between the fetus and the mother. Growth of placenta occurs throughout pregnancy, which make assessment of its thickness and volume possible. The second component of this research is actual birth weight on scale, which is the body weight of a baby on a measuring scale after delivery. The aim of the study is to determine the relationship between placental thickness and actual birth weight, and to see if placental thickness can predict actual birth weight. It is also meant to determine the range of placental thicknesses among the study participants. The method was a cross-sectional, it's a prospective longitudinal hospital-based study whereby 200 pregnant women who are attending antenatal clinic at Udut, Sokoto were randomly selected. They were sent to radiology department for obstetric scan, during which assessment of gestational age, placental thickness were carried out. They were then followed up to delivery to obtain the actual birth weight of the newborn babies on scale. Some of my inclusion criteria are pregnancy at 34 to 40 weeks, history of regular menstruation, and so on. Some of the exclusion criteria are maternal hypertension, diabetes, anemia, placental abruptio, placenta previa, and so on. This is a sonogram. Please, I have problem with the
IT.
I can't use the
Take control of the. Wait. When you press one, you wait.
So this is a sonogram of a gravid uterus showing the placenta at the point of insertion of the umbilical cord. The tubular echogenic structure represents the cord. Measurement of placental thickness is done from the point of insertion of the placenta to where the placenta attaches to the endometrium. The vertical distance is obtained. Please, I have problem with this.
IT. Can we temporarily?
Okay, this is another sonogram, longitudinal view of the fetal skull, showing the landmarks for biparietal diameter measurement. The landmarks are the echogenic midline structure, the pars cerebri. On either side of the pars, the hypoechoic ovoid thalami, and then the cavum septum pellucidum, which is a CSF filled space between the anterior horns of the lateral ventricle. Another sonogram, longitudinal view of the fetal thigh, showing the highly echogenic tubular structure representing the femur. Measurement of femoral length is done between the V-shaped ends of the femur. And the corsal have to be parallel to the shaft. Table 1 is showing the socio-demographic characteristics of the study participants, the different age groups, ethnic groups, level of education, and occupation. The different frequencies and percentages, as well as the cumulative frequencies, were also shown in the table. Figure 4 is a bar chart showing the distribution of parity among the study participants. Multiparous women forms the majority group, followed by nulliparous, then primiparous, and then grand multiples. Figure 5 is a histogram showing the distribution of gestational ages in weeks among the participants. Age group 36 forms the majority, followed by 39 weeks, and then the list is 40 weeks. Please, it's not. Table 2 is comparing the mean and the gestational ages, the mean placental thicknesses, and the mean actual birth weights in the different weeks. As we can see, hello, there is problem with this. Okay, as we can see in this table, the mean placental thicknesses and the mean actual birth weights were found to be increasing as the gestational ages are increasing. Table 3 is showing it's moving on by itself. Even if I didn't press, it's just moving.
Yeah,
yes,
previous.
Previous slide, please, not this one. Previous again. You can't. So table 3 is showing the mean placental thicknesses and the mean actual birth weights. In this table, we can see that pipe deliveries were low birth weight less than 2.5 kilogram, 187 were term normal deliveries. I mean, birth weight between 2.5 to 4 kilogram, and then 8 deliveries were macrosomic, birth weight more than 4 kilograms, and the mean actual birth weight, mean placental thicknesses were as shown in the table. Next. Next, please. I can't, it's not showing anything.
It's not, you can use the,
Recording in progress.
I use, okay.
wait,
A Pearson's correlation coefficient was carried out and regression analysis was done. The coefficient of correlation was found to be 0.291, which is about 29% between actual birth weight and placental thickness. Table 4 is showing the range of values of placental thickness in the study group. For each gestational age, the range is given. At 34 weeks, we have 17.4 to 21.6, while at 40 weeks, 30.4 to 39.8. In conclusion, placental thickness at 34 to 40 weeks was found to have positive correlation with actual birth weight and can be used to predict actual birth weight. And the range of placental thicknesses among the study participants was found to be 17.4 to 43.9 millimeters. Placental thicknesses that are greater than or equal to 43.90 plus minus 4.32 millimeters were found to be associated with macrosomia, while thicknesses that are 23.88 plus minus 3.85 millimeters were associated with low birth weight. These are some of my references. Thank you.
Thank you very much. We apologize sincerely because of the IT hitches that we encountered during the presentation by Dr. Dalat. Nevertheless, I hope the IT fix the problem. They can use the screen rather than the laptop if it has problem. We go to the next presentation. Nevertheless, we welcome Mr. President, MD Khan, Professor Mohammed and his entourage. Thank you very much. You are welcome, sir. Thank you. Yes.
Thank you, sir. So we'll move to the 10th presentation of the 10th abstract. Abstract number 10 to be presented by Dr. Ridwan Mustafa, Hirschsprung's disease, two-year barium enema experience at FTH Katsina. Thank you.
Dr. Ridwan, you are welcome. You have 5 minutes to present.
Good morning, everyone. I'm Dr. Ridwan Mustafa, presenting the Hirschsprung disease, a 2-year barium enema experience at FTH Katsina. Hirschsprung disease is a condition resulting from absence of enteric neurons. It is present in about 1 in 5,000 newborns. The types include short, ultra-short segment, long segment, and sometimes total colonic aganglionosis. The short segment type constitutes the majority, more than 75%. Barium enema is used to investigate this patient, while the genetic diagnosis is by histology. This is a 2-year review of 36 barium enema between January 2022 and December 2023. The purpose of the review is to find the presence and type of Hirschsprung disease, correlate the histological findings, and to compare with what is obtainable in the literature. Next. So we can see the age group of the patients. About 50% of them were infants, while others, then the age range ranged from 6 days to 11 years, with a median age of about 7 months. Sex distribution, just slight, 56% of them were males, while 44% were females. Then these are the findings. The normal findings constitute 39% of the patients, while ultra-short segment forms about 28% of the patients, while short segment types were 33%. So of those that were abnormal, majority were short segment H-Sprung disease, then followed by ultra-short segment. Then this is the rectal biopsy. 50% of the patients had rectal biopsy. All patients with short and ultra-short types that had histology were all confirmed. That is 9 and 5 patients in both groups were confirmed by histology as obtained from the barium enema findings. Then 3 patients were confirmed negative on both barium enema and histology. Only 1 patient had positive histology despite negative barium enema findings. So this is a patient that had a short type H-Sprung disease. You can see the first image on the right, which is the prelim. Then the second image, which is the barium enema study, showing the narrowed segment in the distal rectum and the funneling and marked dilatation of the proximal rectum and sigmoid colon. While this is the 24-hour delay, showing the significant retention of barium in the Bowe loops. Next image, next slide. Then this is the other patient. We can see in the barium study, that's the central image. There's no area of narrowing in the, we can't really appreciate any area of narrowing in the study, but there's significant barium hold-up in 24-hour delay. So that is what we use to suggest ultra-short segment H-Sprung disease because of the significant barium retention. Next. This image also had no area of narrowing, and there's no barium hold up in 24 hours. But this patient was said to have H-Sprung disease that was histologically confirmed. So the age range and median is similar to that what is obtained from previous Nigerian studies. Most of the patients, however, said to present in the antenatal period. That's from previous studies, highlighting delayed presentation in this environment. Also, the age at diagnosis of ultra-short segment were found to be significantly higher than short segment type from a study by Exeter in China. Significant numbers of females were also seen in this study, unlike typical ratios of 3 to 4 in other studies. So short segment type constitutes about 55%, while the ultra-short type 45%, which is very high. It is documented to be a rare type in previous studies. So ultra-short segment type is commoner in our settings than what is reported. That's as a conclusion. Rectal biopsy can be carried out in patients with high clinical suspicions of H-Sprung disease despite normal barium enema findings. Non-retention of barium after 24 hours does not exclude diagnosis of H-Sprung disease. So these are my references. Thank you for listening.
Thank you very much, Dr. Ridwan.
So thank you, Dr. Ridwan. Just to confirm one more time, is Dr. John Sunday available? Dr. John Sunday, or is he available online? Dr. Chinedu Anunasu, is he available online?
Excuse me, the presentation will be done online.
Yes, Dr. Chinedu.
Yes.
Okay, who is the presenter?
The IT, kindly check. Chinedu.
Who is the presenter, please? Chinedu. Is he online?
Can you please communicate with him that we are waiting on him to log on?
Okay, Dr. Goodness Ibe will present on that. So we'll be presenting abstract number 1, malignant middle cerebral artery infarct, medical management, to be presented by Dr. Goodness Ibe.
Yes, sir.
Yeah, IT, he is ready for you. Just show the slide.
Please share because it's not, I'm being declined to share.
Yeah, exercise patient, they are working on it, trying to share your slides.
Number one.
Okay, you can go on, please. You have 5 minutes to present. At the end of 3 minutes, we'll give you, alert you on the remaining 2 minutes by clicking on the mic. So you can go on. Hello? Is the presenter still online?
Good morning, everyone.
Yeah.
Good morning.
Good morning. You can go ahead, please.
I'll be making a presentation on malignant middle cerebral artery infarcts, medical management. Malignant middle cerebral artery infarcts remains one of the challenging medical conditions to treat in clinical medicine due to the pressure effects of massive cerebral edema. These patients are at risk of neurological deterioration or death. As such, should be treated in an intensive care unit in a comprehensive center. This is a case report of medical management of malignant middle cerebral artery in a 53-year-old hypertensive with poor compliance, presented with sudden loss of consciousness, with GCS of 9, best eye opening of 2, best verbal of 2, and best motor of 5. Left-sided hemiplegia, slurred speech, and difficulty swallowing. He came in with an NHIS stroke score of 28, and a brain CT scan confirmed right massive middle cerebral infarct with significant mass effects. He was admitted and managed for malignant middle cerebral artery infarct in intensive care units with osmotherapy, corticosteroid, temperature modulation, cardiopulmonary support, head positioning, which relieved pressure effects in the brain significantly. While on admission, the NHI stroke score reduced to 13. He was discharged after 11 days and was placed on secondary stroke prevention and neurorehabilitation. He has been on regular follow-up with remarkable recovery. There's a CT scan of the named patient. In conclusion, medical management through intracranial pressure management has proved to be very effective in the management of malignant middle cerebral artery infarct and can be adopted in this management. Thank you.
Thank you very much for this precise presentation, keeping to the time. Well done. It's the same presenter having the third and the fourth abstract, isn't
Number
it?
3, yes, same presenter. Number 3. Abstract number 3.
Okay. Are you there? You can go on.
Okay. I'll be taking the presentation on seizure manifesting as behavioral disorder, mesial temporal lobe sclerosis. As a background, seizure, despite being a familiar disorder, still presents a diagnostic challenge to neurologists. This is mainly due to the varying presentations and wide margin of etiological factors. It's usually difficult to diagnose atypical presentations, particularly presenting as behavioral disturbances. Mesial temporal lobe sclerosis is one of the causes of atypical presentation of seizure. This is a case report of a 34-year-old nurse with behavioral disturbances of about 8 years duration, characterized by self-harm and bouts of aggressiveness. There was history of convulsion. There was history of jaundice on the second day of life and febrile convulsion at infancy. She has been managed by a psychiatrist for a while with no resolution. As such, was referred to the neurologist. An electroencephalogram was suggestive of generalized epilepsy and mild encephalopathy with no lateralizing feature. Brain MRI showed a hippocampal asymmetry, right smaller than the left. The right mesial temporal lobe demonstrated a T2 hyperdensity with loss of internal architecture, confirming a right hippocampus/mesial temporal lobe sclerosis. She was managed for mesial temporal lobe sclerosis and anticonvulsant was commenced. She's currently on regular follow-up and has improved significantly. This is the MRI of the named patient. In conclusion, this highlights the importance of considering mesial temporal lobe, particularly in patients with history of behavioral manifestation. Thank you.
Thank you very much.
Also to be presented by Dr. Ibe.
No, okay, you can go ahead, please.
So the third presentation is on posterior imbalance, the case of posterior cerebellar artery infarct mistaken for a benign paroxysmal positional vertigo. On background, posterior cerebellar artery infarct is one of the uncommon stroke and can present a diagnostic challenge, particularly when presenting without a neurological deficit. These symptoms could mimic a benign paroxysmal positional vertigo, especially when it presents with only vertigo and ataxia. This is a case report of an 83-year-old hypertensive with poor compliance. She was referred from a peripheral hospital with complaints of vertigo and loss of balance of 2 weeks duration with no neurological deficits, no hearing loss or visual problems, no dysphagia, no dysarthria, no problem sensing pain or temperature. Brain MRI showed restriction to the diffusion of DW1 sequence on the left cerebellar hemisphere, confirming a left cerebellar infarct. She was admitted and managed for a posterior cerebellar infarct. She was discharged after 11 days and placed on secondary stroke prevention and gate therapy. She's currently on regular follow-up. In conclusion, posterior cerebellar infarct can present without a neurological deficit, and such can mimic benign paroxysmal positional vertigo. This case highlights high index of suspicion of posterior cerebellar infarct, even without a neurological deficit. Thank you.
Thank you very much. Please, we shall appreciate her. Thank you. Now, the last presentation, Dr. Aisha, I think we have only one.
We have only one. John Sunday, I don't know if he's around. Dr. John Sunday. Is he online? Okay.
Is there anybody online? IT? Okay.
It's just the questions and discussions.
So we go for repertoire. You can, Dr. Meshanu, can you kindly please give us the summaries before we entertain questions and answers? Thank you.
Okay, good morning all, with all protocol duly observed. The first presentation was on the prevalence of acute coronary syndrome in Aminu Kano Teaching Hospital, presented by Dr. Garba, where he reported that commonest age affected were 50 to 59 age group, and then the hypertension was the risk factors that predispose most of these patients. And hence, STEMI account for 60% of those cases. And then he encouraged us to increase awareness, because it's a common disease, such that we can be able to pick patients early and manage accordingly. And then the second presentation was on a case presentation on idiopathic scrotal calcinosis, presented by Dr. Abakar Isiaku. The commonest age affected by this disorder is from 20 to 40 years old. He told us that this disease is a disease of theory so far. Nobody knows the real cause of this disease. So, and then in the index case he presented is a case of a 40-year-old with scrotal swelling, with both skin manifestation and internal deposition of calcium, which was confirmed by histology. And then the treatment, as he told us, was basically observation. It can be treated medically or surgical, as the case may be. And then the third presentation was on the predictive value of placenta thickness using ultrasound scan in determining the baby's weight, which was presented by Dr. Dalha. A case study, a study shows that with increase in the placenta thickness, there is associated with increase in the weight of babies, which shows positive correlation. And then the fourth presentation, which is on H-Bron's disease, a 2-year barium enema experience at FTH Katsina, presented by Dr. Rilwan Mustafa. And he told us that it's a case presentation. The presentations usually, patients present between the period of 6 days to 11 years, and then there is male preponderance of about 3:1. And then that the short segment, usually is the majority of the cases that presented were the short segment types. And then the fifth presentation was on the malignant middle cerebral artery infarct, medical management, from presented by Dr. Ebe GD from FTH Owerri, where she reported on a 53-year-old hypertensive who presented with a GCS of 9/15, and then the brain CT scan confirmed that there is a cerebral artery infarct, and then she was managed in the ICU via intracranial pressure management, and patient did well, and then they are currently following up the patient. And then the sixth presentation was on seizure disorder by the same Dr. Ebe GD, where she presented a 34-year-old nurse who presented with behavioral changes, and then EEG shows generalized epilepsy, and then MRI shows hyperdensity. She was also managed with anticonvulsants, and they discharged her there. Then the last presentation was on disequilibrium, a case of posterior cerebral artery infarct mistaken for benign paroxysmal positional vertigo, presented by Dr. Ebe GD. She presented an 83-year-old non-hypertensive who is now regular on follow-up, that presented with vertigo and loss of balance. And then MRI confirmed that she has left cerebellar infarct. The teaching here is that when patient present with vertigo, what look like benign paroxysmal positional vertigo, we should also note that they may be presenting with cerebral infarct. So we should be on the lookout for, so that we can be able to manage appropriately. And then they manage her medically and discharge her, and she's currently on follow-up. Thank you.
Thank you very much, Dr. Meshadu, for this. Round of applause for him, please. Thank you. We go to the questions and answer session. We have to be brief, and we just have 10 minutes for that to respond. When it comes to the online, we will allow the presenter to listen and note the presentation, and allow her instantly to respond to the questions. So please, can we entertain questions, comment? One, Mr. President. Two, President MD Khan AKTH, Dr. Busana Isa. Three, any other questions? So we start with Mr. President. Please, the mic should be taken to.
Good morning, respected delegates. Mine's comment on two presentations. Idiopathic scrotal calcinosis. Yes, we know the common age 20 to 40, but it do occur in children. We have reported 2 cases in 2013 in the archives of international surgery. And the etiopathogenesis could be both metastatic calcification or dystrophic calcification. Metastatic, if you check the serum calcium and it's normal, then it's dystrophic. If the serum calcium is high, then it could be metastatic, which can be deposited in a normal tissue. But dystrophic could be as a result of infections such as a boil that will leave a scar, and then calcium will be deposited. Could be trauma, could be many other things. Even though there are many theories suggested, but none of them is really pinned. Probably that was the reason for the conclusion. The second comment is on the use of barium enema in ultra-short Hirschsprung disease. Sorry, I am biased. I'm not commenting on the neuro submissions. Puto will bear me witness. Yes, what is obvious error, I can't say error per se, something that is not taken into consideration was that you will always likely going to miss ultra short if you take your x-rays with your catheter and the balloon inflated in the distal rectum. And that is one of the major reasons. Even in the case you illustrated, the catheter was there. So you will always likely going to miss that on barium enema. For ultra short, you make the diagnosis after depleting your balloon and removing the catheter, because that balloon is occupying where the ultra short should show. So please take note anytime you are doing that. Thank you very much.
All protocols duly observed. I'd like to stand on existing protocol in case that has been established. I'd like to commend the presenters for their lucid presentations. However, I'd like to comment on the last presentation, actually. The 83-year-old with vertigo and an incidental finding. So in the title, it says posterior cerebral artery infarct. But during the presentation, I seem to understand that it is posterior cerebellar. So in any case, the posterior cerebellar cerebellar artery actually, I would have loved to see the brain CT or MRI or angiography to really buttress that fact. Because if you say posterior cerebellar has branches. And are we talking about the inferior branch or the superior branch in this case? In fact, the inferior branch, it gives you one of the brainstem syndromes. So this patient will not come without neurologic deficit, without some other lateralizing signs. But if it's a superior artery, possibly that could, even with the superior artery, patients would definitely come with. So the fact that this in fact was discovered, as an incidental finding, and that was put as a case to support vertigo in an 83-year-old person, really, I think she needs to be checked again. I am a rheumatologist with some bias in geriatrics, so I know that dizziness and vertigo can be very, very fairly common in elderly people. And though, of course, she didn't show us the images, this is one of the things I have picked out of that presentation. And then we need to know how this patient actually fared after whatever treatment modalities the patient received. Thank you very much.
Thank you. Yeah. Is she online? Can she respond? She needs to respond to this to clarify some issues raised by Dr. Musa Ofrana Isa.
Good morning.
Yeah. You're welcome.
You're welcome. Thank you.
IT. One of the co-author is here physically. She can respond to that comment. So you can go on, Ma.
Thank you for your clarification, but I think there's, I don't know how, because from the presentation there was never a place cerebellar artery was mentioned. Rather, or if she mentioned it, then it was a mistake. Because what you can see in an MRI is just an infarct. Are you getting what I'm saying? Unless if there is an angiogram, that's where you can pick the infarct of the vessel. So actually what we saw was an infarct on the left cerebellum. Are you getting what I'm saying? So that was why the diagnosis was left cerebellar infarct. So I don't know where superior,
Recording in progress.
inferior or superior artery, cerebellar artery infarct came from. Then that patient was seeing the ENT because of the vertigo and the ataxia. So most times you find out that when the patient, like that other lady that presented the mesial temporal sclerosis, mesial temporal lobe sclerosis, that has been visiting the mental health physician before coming to our clinic. The same thing applies to this woman. She was seeing the ENT. So when they now found out that she was not getting any relief, that was when she was now referred to neurology clinic. And the MRI, because of the position of the cerebellum, you find out that with the CT, you may not be able to pick the infarct. So it was actually the MRI that was requested for. And it showed a left cerebellar infarct. With management, the woman did very well and physiotherapy, so she can now walk. Are you getting what I'm saying? So most times we find out that we really need to spread our tentacles. We don't need to be narrow-minded. If you think like this and you're not getting what you want, always try to reach out. It is very, very important. We didn't do an angiogram because when we now saw the infarct, we now managed, and the woman started getting better, so we didn't do an angiogram on that, because you need to always consider your patient's pocket too. Thank you.
Thank you very much with this response. The last person, yeah, you can come on, please. My teacher, Prof. Garku. You are welcome, sir. Yeah. Okay, you have this. After him, Prof. Somaila also want to respond.
Thank you very much.
Before Prof. we announced the arrival of the last presenter, Dr. Sondi. Please get prepared. After the finish question and comment, you are to present. Thank you very much. Go on, sir.
Yes, thank you very much. I want to commend all the presenters. This stroke issue is what I want to also comment on. You see, investigations come after clinical assessment. Now, cerebellar artery stroke and posterior cerebral artery strokes are well-defined entities. They are well described. What was described in the symptoms is clearly a cerebellar state. But to say it's posterior cerebral artery, the symptoms of posterior cerebral artery and signs are just mild headache and visual symptoms. So it will be difficult to convince anybody listening. I'm not a neurologist, but if we have a neurologist, they should please come and dissect the neurology and the blood supply for us. But it's difficult to actually sell that as a cerebral artery stroke. It's more in keeping with cerebellar artery stroke, which has been well described in any book of neurology or even our own books. Just check any book, it's clear. My second comment is on the presenters. It's good to stand up and present, but please work on your confidence. When you stand here, this is your pulpit, you talk, because it's your work. Some people, I was like coming to tell them, go on like, you're not afraid, you should talk with confidence, please. Thank you very much. Mungode.
Thank you, sir. Professor Maila, you can respond.
Thank you very much, Chair and the House. My comment also is similar to what Garko has said, and this boils down to our clinical practice. There was no reason why this patient will stick with ENT in the first place. If it was vertigo only, then somebody can send to ENT, check why the patient has labyrinthitis, meningitis disease, but there was ataxia. So why should somebody with vertigo and ataxia be sent to the ENT in the first place? So I think it's our clinical acumen, as Professor Garko said, with ataxia combined with vertigo should have assessed neurologically from the beginning. It was later that referred the patient for this MRI. And when the rapporteur was saying he was talking about density, I think for MRI we talk about intensity. Thank you very much.
Thank you, sir. Sorry, one more response from online. There was a question for Dr. Abdullahi, which presented by Dr. Garba. I think, Dr. Garba, you can read the question. What part of the data presented supports the conclusion and recommendation of more training, considering the fact that 76 and 83% knowledge score was recorded and presented? So, as far as the person question, making the question concerned, that there will be no reason, because they have already reached that level of significant knowledge. If you have any response, you can go ahead, please.
Good morning once again. I think the part that needs more training is the emergency training. The score was very low, was 40-something%, which is low. So recent training, emergency training in identification and management was low among the dentists. That's what made the conclusion and recommendation for more training.
Okay, thank you very much. So thank you very much. We thank everybody for for the attendance, and then particularly the presenters. We thank you very much for presenting your valuable research work. Thank you very much. I hope you take the lesson from Prof. Garku, from Balarabe Garku. What he said, that you should take the stage when you come to present your papers. Thank you very much once more. We thank everybody. We thank the FD Khan for giving us this opportunity. Thank you all. The session is hereby closed.
Good morning once again. Good morning once again. Please, as we're waiting for the tea break, we're going to have a short presentation on vaccine preventable diseases by WHO. Thank you. So we're just getting ready. Thank you.
Just try it.
Terminal like this. Can I climb up? Yeah?
Hello. Music, can it go down? Thank you very much. You can start. WHO, please go ahead.
I should go ahead?
Yes, you can start.
Okay. The chairman of this conference, senior colleagues, good morning all. My name is Umer Gregory. Just a quick presentation on the vaccine preventable disease and surveillance and response. As we know, this week is actually African Vaccination Week. Globally, especially in Africa, where we have a lot of vaccine preventable disease, the week is for immunization from 24th to 30th of this month. We are focusing on making sure that all eligible children and adults get the vaccine they need to be protected. So I'll just quickly look at it. What is the burden? We know that the burden of vaccine preventive disease is much. What are the diseases that we are targeting for control, for elimination, and for eradication? There are many. And then what are the dynamics of infectious disease? Importance of vaccination, surveillance, and VPD case definitions. What are the challenges to vaccination? And then how do we improve vaccination across life course? And also, what is the role of stakeholders like doctors and the other health workers? And what is the call for action? That's actually where we're going to lay more emphasis, because we all are aware of vaccination, but what do we need to do at our own levels to make it work better? If you look at it, measles alone is claiming a lot of lives. In 2022, over 130,000 children died, mainly children. And then mainly young people that are affected by VPDs, because these are the ones that don't have the strong immunity and are the ones that are still trying to develop their system. And then these are the diseases. Recently we added measles, malaria to the vaccine preventable diseases in Nigeria. We had an introduction sometime last year in KB and Bayelsa State. So it's already part of our routine immunization. Malaria vaccine is part of our schedule now. So it's going to be introduced in all the states this year. So it's something that we're happy of. HPV was also added sometime last year. We have Rota added and the other diseases. So it's not something we need to really make our children, especially the pediatricians, they need to make sure that when the children are delivered, they are linked to the services. And then what are the goals? Eradication, elimination, and control. These are very difficult, especially with, the only case that we've eradicated so far is the measles, the smallpox vaccine, smallpox infection in 1978. So, but we're trying to see if we can do same with polio. It's not an easy thing. Measles is difficult because of the life cycle and all that, but we can do that with other combination. And then these are the strategies if you want to, if you want to control any disease, eradicate and eliminate disease. You must have strong routine immunization, which we know is not actually what is happening in Nigeria. Then you must also have national immunization days so that you reach out those people that have missed for one reason or the other. Then you need strong surveillance system to know where are the diseases, where do you need to pay more attention, which are the age group involved, what are the barriers, and what do you do. And then you have mop up when you have outbreaks and all that. Then if you look at the dynamic infectious diseases, we should know that it's not just the disease and the host. There's also the role of the environment. There's also the role of the climate, the role of biodiversity, and then the host. So when you put all this in together, then you know we must go for one health approach. So that we look at the environmental health, we look at animal health, and then also the human health.
And then the importance of, I just mentioned the major importance of vaccination is something we are aware of. Life-saving and protect the health of population, improve country productivity and resilience, enabling a safe, healthier, more prosperous world, and then antimicrobial resistance. This is something we need to pay attention, because the more we don't prevent the diseases, we keep treating them, they have resistance. So we don't have the drugs to even treat the severe cases. So to prevent antimicrobial resistance, we need to also make sure we intensify effort on prevention and use of vaccines. International health regulations require that without, if you don't have yellow fever card, you can't travel to countries and all that. It's through vaccination that you get all those. Achieving the SDGs, vaccination, the SDG 3 focus on health. And then what are the challenges? Mainly issue of trust, issue of safety, and the issue of no felt need. People feel what they need is food, they are bringing vaccine and all that. So we need to combine that. And then inequity is also an issue. The burden of disease is more in African countries, but those people that manufacture the vaccine are more in developed countries. We don't have the money to pay for this vaccine. Without Gavi and World Health and World Bank, we can't have these vaccines. So we need to also invest in this vaccine. Why can't Nigeria produce vaccines we need? So we need to also invest. So it's an issue, it's a challenge. And then population movements, conflicts affects vaccination. Then immunization across all ages is difficult. Now we have COVID vaccine, which adults can get. We have hepatitis C vaccine, which adults can get. But how many people go for these vaccines and all that? Then climate change and natural disaster make it difficult to reach some people. Then conflict and potential instability is a challenge. Outbreaks and optimizing and maintaining supplies are challenge. What are the strategies do we need to improve vaccination? One is cooperation of design from the bottom top, tailored to the national context, adaptable changing needs, and then targeted to reduce inequality and inequity, and then gender response strategies. Sometimes you need to also look at gender, which gender is left behind, and how do we mainstream them and then get everybody on board. And then stronger focus on system strengthening. System strengthening is key. And if you notice, our primary health system, primary health care is not working as it should work. If it's working very well, all the PACs are able to deliver all the services with the minimal interference. And then life course approach, so that people, both adults and children, get these vaccines and then protect them. Then strengthening partnership. We can partner with the government, partners with other development partners to get things done, researches and all that. This also help. Accelerating innovations. We can deliver vaccine by drones and all that in conflict area. This also helps. And then better use of resources for self-sustainability. Then roles of immunization stakeholders. Immunization in primary health care. At our facilities, general hospital, our primary health care center need to be well equipped to be able to deliver these services. Leadership, governance, and management. You know, planning with the immunization people to know where we need these vaccines, when we need this vaccine, and all that. Providing budgeting is also key. And the health workforce. We don't have the health workforce to deliver this vaccine. In some places you go, you find out the health workers from primary health center are the one giving vaccine in tertiary hospital and then in government general hospital, which it shouldn't be there. We should have our own staff delivering the services. And then supply chain and logistics is something we need to improve on, working with stakeholders. And then surveillance is key. We need to detect these diseases. We need to make sure they are investigated. We need to get results and use those results for action. Most time we don't get results. We just based on suspicion, and then the outbreak keep going and all that. And then health information system is key. Monitoring vaccine safety, and then disease control initiative. Then these diseases, like we know, acute flaccid paralysis, children less than 15 years with sudden weakness of the limbs, we need to report them, and then investigation. Measles too, we need to report measles. This is differentials for acute flaccid paralysis, which what we used to detect polio. Because any child, anybody less than 15 years with flaccid paralysis, is polio or proven otherwise. You need to investigate what is the cause. In that case, you'll be able to now make sure your system is sensitive and also specific, so that you can now prevent transmission. Measles, something we also need to look at. Rashes, high fever rashes, and then any of the disease, conjunctivitis, coryza, or cough. We need to also investigate that. Which are the rashes? Some causes of rashes and fever we don't really look at for them, but these are the likely differentials you can look at. Rubella is here. Recently, we are planning to introduce MR, measles rubella vaccine, and remove the measles vaccine. So hopefully by this year we are going to do that, because we notice some of the cases of measles and rashes are due to rubella and not measles, and we think it's measles, and then we are not looking at rubella. So we want to add rubella to our vaccine this year. And then neonatal tetanus is also key. We need to also look out for that. Yellow fever, cholera too is key. These are diseases we can prevent by hand wash and hygiene and all that. And there's vaccine for cholera too, but the key is actual prevention. And then meningitis, we also need to look at that. Viral hemorrhagic fever, tuberculosis, COVID-19. This is the network for reporting from facilities to the LGA, to the state, and to the national. So every facility, whether general hospital, tertiary facility, must report to the LGA, to the state, and then state to the national. And then what are the call for action? This is actually what I want to really pay attention. Most times as doctors, we don't pay interest in disease surveillance. We treat the patient, they go, but where are they coming from? It's the tip of the iceberg. If we don't pay attention to where they are coming from and the likelihood of other diseases in those places, we are going to have cases coming and we'll never get out of that. We don't have time to do research and all that. So we need to pay attention to the diseases, where they're coming from, make diagnosis, and use those diagnoses to see, do we have more cases where they're coming from? And then our reporting to the LGA we will not say because we're a tertiary facility, we will not report to the LGA. We need to report to the local government, because it's through the local government to the state that the data will be seen at the national level. And then the third case is using the standard case definitions. The case definition for acute fibrosis paralysis is different from the case definition as a clinician for polio. So, because for public health, there is that issue of sensitivity. So we widen the scope wider so that you don't miss cases. And then support diagnosis of infectious diseases and do not stop at suspicion. Follow up the result of samples and results for decision. Have infection control, infection prevention and control units. Some people have it, but it's not working. Do you have an IPC unit in your facility, and do you meet regularly? Do you review their performance, and do you enforce it? Yeah, so we need to really do that, because that is key. Because without that having an IPC, health workers, like lost some colleagues sometime in Nasarawa from Lassa fever, if there's a strong IPC, that will not happen. They will be able to review those mortality and take decision and make sure it doesn't happen again. And then we also need to enforce standard precaution, use of PPEs, availability of PPEs, regular mortality meetings, yes, to discuss with colleagues. And colleagues, epidemiologists, we can invite them to give us data about the state. We can invite partners working in the state to give us data about this, and we use that for action. We can't just work alone. And then we should need to partnership. Can use this.
You are welcome, sir. That's it,
When we say that she's someone later us.
Okay. Amaza JT break.
This one.
Shiko. So za a fara wannan kenan.
Sai ku yi tunani. Hello. We welcome the Honorable Commissioner, Ministry of Health, Kaduna State, Honorable Musa Adamu Funtua. You are welcome, sir, and you are encouraged. Thank you. Round of applause, please. We shall appreciate the Honorable Commissioner. Thank you.
Thank you very much, sir. We want to have a short tea break, just for 10 minutes, so that we can start either the opening ceremony or the panel discussion. Please, if you look into your bags, you have the tea break tickets there, so we can quickly have a tea break for 10 minutes. There are 3 points, one in the front, I think one at both sides, just for 10 minutes, so that we can quickly begin the opening ceremony. Stand up. Sorry, it's time for a tea break, please. Are they ready? Nowhere to turn. Love can seem so far away. I'll be your shelter in the eye of the storm. Just believe in me when I say you can call my heart your home. Tea break, sir. This way, tea break. Yes. Yes, it's ready. It's ready. Or we should just go ahead and have opening ceremony? The working.
No. We have a panel.
That's what I'm saying. Do we go ahead?
Let's have a working tea break so that
fine.
so that we can save time as we are discussing as panelists. We need to move on to one stop. So immediately after the prayer, we have concluded the panel.
Thank you. Dr. Aisha? Dr. Aisha?
How many minutes are you going for the tea break?
So you should go concurrently with the panel discussion.
Yeah.
Yes. Can you help me show that?
Who are the panelists?
I will start inviting them.
Are they using slides?
No.
Okay, so we will tell them to switch you to high table so that you can sit.
Hello? Yeah, cooking. Nothing, hello? Imagine. Hello? Imagine. Bakukama passport. Bakukama passport. Any application passport. Why does somebody they came up with a check the tour international passport? I must be on the tour or you have an alternate arrangement, eh? I need the passport number now. Those people that are going so that you tour.
Good morning, virtual and physical participants. While we are on the tea break, we would like to use this opportunity to showcase the online and conference registration page designed by the ICT unit of the MDCAN, Kasin and DICO. So, as you are all aware, when the link was shared during registration, you went through process of putting in your names, email, WhatsApp numbers, center, specialization, payment, which is all captured, and as you can see seamlessly, the checking in of participants went on using the barcode scanner. So this is the page showing the conference dashboard of the MDCAN NEC meeting, Kasinan Diko, April 2025, with the theme enhancing national health security, the critical role of medical and dental consultants in promoting equity and innovation in Nigeria's economically challenging landscape. As you can see, this is the summary of the conference leadership with the LOC chair and then the MDCAN president. And this platform can further even be edited to take in the members of the LOC, the members of the NEC meeting. So this is Dr. Yusuf Musa, the LOC chair, as you can see, then the president of the MDCAN, Prof. Muhammad Amin Muhammad. So this shows the attendance overview with a total of about 238 registered participants. Then with the barcode scan, we checked in 111 participants while 127 are awaiting check-in. We have a lot of virtual participants numbering about 70. So right now we will be checking in their barcode. So the number of the checked-in participants will display. And you can see the summary of the participation type. Majority selected the physical option of about 170 participants, while 68 registered the virtual option. And you can see the top 5 states from the statistics, with Katsina having 107 participants, followed by Kaduna 13, Kano 10, Ebonyi 7, Lagos 7. So even though we have some challenges with flights, so some of the participants were able to switch from physical to virtual. So this is the dashboard. Okay. The dashboard offers a lot of options. You can even see the amount the participant paid. For example, Yahya Mohammed from Sokoto or Omotola or Bajolo. So this is the summary. It will show you the statistics of the amount paid and the pass that is issued. Then this platform also has the option of sending the digital certificate of attendance to the participants at the end of the conference. Automatically, it will view the certificate and send to the participants. So these are some of the features that this site offers. So thank you very much. If you have any question or comment, you can please come to the IT desk. Thank you very much.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, good morning, good morning. We are about to begin the opening ceremony of Katsina Dikko April 2025 NEC of the Medical and Dental Consultants Association of Nigeria, the MDCAN. And I remain humbly yours, the scribe of the association, Ayabu Alhaji Ibrahim, and I will be flanked by my friend, colleague, whom we have been together for over 35 years, and my classmate as well. He will help me anchor the program. He's none other than Dr. Hakim Badamasi, an erudite nephrologist who has been taking good care of Katsina Dikko for almost 2 decades. He has already acquired the indigenship and citizenship. Soon, possibly in the year 2050, I will be the campaign for Badamasi for governor of Katsina State, but that will wait until 2050. So, ladies and gentlemen, you are all welcome, and we'll begin calling for the dignitaries so that we can buy time. Already we are behind schedule, and if you open your brochure, you will see the program of events for today on page 21, and we'll begin by recognizing the presence of Malam Dikko Umaru Radda, PhD, CON, the Executive Governor of Katsina State, who is our special guest of honor. Because of the exigencies of his office, he is ably represented by none other than Honorable Musa Adamu Funtua, the Honorable Commissioner of Health, Katsina State, who also doubles as our guest of honor for this opening ceremony, and he has already been seated with us for the last almost 30 minutes.
You're welcome, sir.
Together with his entourage. Please, sir, the representative of the governor of Katsina State, Malam Umari Dikko Radda, PhD, CON, put your hands together as he takes the seat of the podium.
Where are the horses?
Also, we are expecting the arrival of the Right Honorable Nasir Yahya Daura, who is the Speaker, House of Assembly, Katsina State, who is to be the chairman of the occasion, and we learned he will soon be around. We also have the wife to the Executive Governor of Katsina State, Her Excellency Hajia Zulaihat Umaru Dikko Radda, whom we are expecting to come any moment. As usual, we really do our activities without the blessings of our royal fathers. And any moment we are expecting their representation. And we have 2 large emirates, both of whom share some ancestry in the Hausa folk with where I came from. They are part of the 7 Hausa states. And proudly standing before you, I belong to the first Hausa state, the Biram, in the Hausa folk. And next to us is, I don't know whether I will be forgiven if I began with calling, recognizing the Royal Highness of Daura, Alhaji Umar Farooq Umar, CFR, Emir of Daura, and then the Royal Highness, His Royal Highness Alhaji Abdul Mumin Kabir Abubakar, CFR as well, who is the Emir of Katsina, both of whom belong to the 7 Hausa states. Our chief host remains the Chief Medical Director, Federal Teaching Hospital, Katsina, Dr. Suleiman Bello Muhammad, whom we are also expecting soonest. Oh, the screen obscured my view. Sir, come to the high table, and he's ably flanked by his C mark, whom my friend will introduce. But before that, I would recognize and call to the high table the host of all of this event, who is none other than my president, our president, your president, Professor Muhammad Aminu Muhammad, president of MD Khan. Sir, come to the high table.
You're welcome, sir. Yes, yes.
So what carry on? So the same.
While we wait for, yes, while we wait for our guests to join us, our royal fathers, well, I agree with you. Professor Beyebu has been a tormentor in chief for years. He has taken all the prizes. I wonder, maybe because my head is a bit bigger than his. They told me he has more coiled cerebral neurons than I do. This is the time to take back from him. Well, this is Katsina, I agree with you. But I've been in Katsina for some years. I think Dr. Naziru will beg to disagree with you. The way you put maybe the royal fathers. But they are fathers, you are welcome. We just want to recognize more people that are within the midst. We have my former MD and a new MD in the midst here. Please welcome to the podium the new MD of the new Federal Medical Center, Daura, Dr. Farouk. Can you help me, Farouk Umar? And what is the most important name? Abdul Majid, you are welcome, sir. Don't assume I've forgotten that. You are welcome, sir. Please join us in the podium. There is a former CMD and the current CMD. Yes. You're welcome, sir. Now, we have so many dignitaries. What of the soul? What are the... We have in our midst the PAM Secretary, Permanent Secretary of the Ministry of Health. You may help me with his name. Sir, you are welcome to the podium, please, sir. Thank you very much, sir. Please join them, sir. Now, before we have our panel discussion, I know we're having an opening ceremony just to populate this.
No problem, yeah. I will do that. As we are doing this introduction, there is a money point ATM card without name that has been spotted somewhere. If you know you lost one, you may come for it. Let me recognize the presence of all NOC members here present, led by the president who is already on the podium, the vice president one, Professor Chidi Apollos Ndukuba from UNTH, Dr. Titilola Ibiemi Sarah from FMC Bekuta.
You're welcome, man.
Where is my, okay, Dr. Yakubu Bababa Shirama from ATBUTH Bauchi, Professor Umar Isa Umar, our national treasurer.
You're welcome, sir.
From Kano, Dr. Godwin Agidzi, our national publicity secretary from FMC Kefi, Dr. Simon Uraya, our auditor from River State Specialist Hospital, Port Harcourt.
You're welcome, sir.
Professor Titus Chukunokwaku. I know, I will be caught on that one. So, he has been our editor of the Journal of the Association from Newi in Anambra State, and the immediate past president, Professor Victor Makanjola. You are all duly recognized. In our midst also is the presence of a past president of the association. As protocol deems necessary, we must recognize Professor Sani Balarabe Garko, our mentor, our teacher, our past president, and one of the invited guests in today's activity as one of the panel discussants. Sir, come to the high table, sir.
That name
Also,
you've not completed that. I don't want to.
MNI.
Thank you very much.
Yes, I have said Professor Sani Balarabe Garko, MNI. So come to the high table. Closely to follow is another past official of an NOC member of MD-CAN almost 10 years ago. He is none other than Professor A.A. Samaila. Sir, come to the high table. Yes. Next to him is another invited panel discussant, Professor Aliyu Abdu, who the two of them are all my mentors, and we are from the same department, not just same center, but from the same department.
You're welcome, sir.
And if in the next 10 years I begin to grow, I want to be like them. Yes. Okay, kindly introduce your successor. I learned he took over from you.
Exactly. And it's been very meritorious. Please join us in the high table, sir. Dr. Nasiru, ENT surgeon par excellence. My two patients are doing very well. We have reverse tourism. Maybe the CMD should know. I had to bring patients from Lagos to have important surgery in ENT. And I got a patient from National Hospital to have endoscopic rhinoplasty, whatever they call it. You are doing very well, sir. We are grateful.
Let me also recognize all other past presidents that are unavoidably not with us, but they are online with us. You are all recognized, sir, including the Board of Trustee Chairman, Professor SNC Anyang, and all other past presidents that are with us online, as well as all past executives or NOC members of MD-CAN who are also joining us online. You are all recognized. Let me equally recognize the presence of NEC members here present physically and online, the chairman and secretaries of our various chapters. You are all duly recognized. My co-moderator will now recognize what I normally call the local content, LOC and all others, please.
Yes, the chairman of LOC, sir, Dr. Yusuf Musa. Where are you? He's busy with logistic. That's one. But even before that, let me bring to the podium the director, Dr. Shamsuddin, sir. Please, can you join up there? I was looking around. So I can afford not to call Dr. Nazir. The worst he would do for me not to do my ECG. No problem. Yes. You are welcome, sir. Dr. Yusuf Musa. Who is the secretary?
Secretary, Special Duties Human.
Okay, I've just been informed the Permanent Secretary, Special Justice, Katsina State Government has just joined us. Please join us, sir. And the name? Yes?
Dr. Laura Rabi.
Oh, Dr. Laura Rabi. Sorry, I'm just looking at the face. When you see many people, are welcome, sir.
Thank you.
We need to, perhaps maybe I'm the least important here. We would have invited everybody upstairs, but we are afraid some other visitors may join us. So if you permit me, it's just to appreciate the LOC for what they've done so far. I had a special treat yesterday at your dinner. I'm quite sure we are going to have interesting opening ceremony, especially the panel discussion. Without wasting too much of our time, I think, sir, we can start.
Yes, this is the opening ceremony, and I think the IT unit, if you are ready, we recognize everybody here present, whether you are a NEC member, an LOC person, or even a guest here present, the security outfits that are here with us, those in uniform and those that are looking like us. We know of your presence. We recognize you, and our people of the Fourth Estate, we duly recognize you for the good work you are doing in getting people to know the activities of this noble association. So thank you very much. Without much further ado, the IT, please get ready for the national anthem. With your permission, sir. So we may all rise
up for the national
for the national anthem. So after a count of IT, can I say after a count of 3? National anthem. We can read it. We can sing now.
Are you sure?
Yes, it's here. I'm sure. I have done that severally. Yes. Okay, let's do it together. Is there? We have a copy of the brochure and it's on the first page, page 01. So we quickly go through it. 1, 2, 3. Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians all am proud to serve our sovereign motherland. Our flag shall be a symbol that truth and justice reign. In peace, O battle honored, and this we count as gain. To hand unto our children a banner without stain. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty Nigeria may be blessed. Thank you, thank you, thank you very much. You may wish to sit down. Next, I will call on our past president, present here with us, to lead us in the physician's pledge. I will call on Professor Sani Balarabe Garko MNI sir to lead us, and so all Hippocratic brethren here present should stand and read the physician's pledge, which is on page 2 of the brochure, please. Why? Okay. Oh. Onto the table? Yes. No, we'll come back. Wait. So. Sorry, sir.
Okay, it's all right. So all medical doctors should please rise and read after me. I solemnly pledge to consecrate my life to the service of humanity. The health and well-being of my patient will be my first consideration. I will respect the autonomy and dignity of my patients. I will maintain the utmost respect for human life. I will not permit consideration of age, disease or disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing, or any other factor to intervene between my duty and my patient. I will respect the secrets that are confided in me, even after the patient has died. I will practice my profession with conscience and dignity, and in accordance with good medical practice. I will foster the honor and noble traditions of medical profession. I will give to my teachers, colleagues, and students the respect and gratitude that is their due. I will share my medical knowledge for the benefit of the patient and the advancement of healthcare. I will attend to my own health, well-being, and abilities in order to provide care of the highest standard. I will not use my medical knowledge to violate human rights and civil liberties, even under threat. I make these promises solemnly, freely, and upon my honor. So help us God. Thank you.
Thank you very much, sir. Please be seated.
Thank you very much. At this juncture, may I call the LOC chairman, Dr. Yusuf Musa Rafindadi, to come forward for his welcome address. Dr. Yusuf Musa Rafindadi. Dr. Yusuf Musa Rafindadi, LOC chairman, or his representative.
Come. Are you scoping today?
Come quickly for your welcome address.
You have a written address? So, quickly.
Your Excellency, the Executive Governor, Katsina State, heavily presented by the Commissioner for Health. Please permit me to observe the protocol duly observed. Distinguished guest, MD Khan present, the NOC, and the Board of Trustees, all our esteemed members of National Executive Council of MD Khan here present. You are all welcome to Katsina. It is a profound honor to welcome all of you to April NEC of MD Khan 2025 tagged Katsina and Dikko, April 2025. As we know, Katsina State or Katsina as a city is a place of rich cultural heritage. We are known as home of hospitality. We are very hospitable, and we have a rich cultural heritage, center for learning, center for education. We have two emirates, namely Katsina Emirate and Daura Emirate, that have been in existence for over 1,000 years. As we convene here in Katsina, we decided to take a very important area of healthcare as our main theme, that is enhancing national health security, the critical role of medical and dental consultants in promoting equity and innovation in Nigerians' economically challenging landscape. This is not only timely, but also essential at this time. It reflects the realities we face as healthcare professionals in our various respected areas of practice throughout the country. Our commitment to promoting health equity and innovation is ever more crucial as we navigate the intricate dynamics of health system amidst these current economic challenges. Our sub-theme, we all know the much kind of discussion and dialogue being conducted regarding the career progression of medical professionals, the issue of leadership in universities, the issue of promotion and rest. That's why we decided to take our sub-theme, the global perspective of postgraduate medical career development, looking into our fellowship and PhD dichotomy in Nigeria. We are privileged to host a gathering of exceptional minds, medical and dental consultants who are leaders in their respective fields, with a shared vision for a healthier Nigeria. Your presence here signifies a collective commitment to advancing our health landscape through collaboration, innovation, and persistent advocacy. I welcome you all to Katsina State, and I wish you a very, very fruitful deliberation while we carry out this meeting in God's willing. I thank you all for your presence, your patience, and you should please try and be more patient with our shortcomings. Thank you very much. May God bless you all.
That is the indefatigable, erudite LOC chair of Katsina and Dukko, April 2025 NEC meeting of the MDCAN, Dr. Yusuf Musa Rafindadi. Ladies and gentlemen, the #1 doctor of Nigeria is joining us. My president, our president, your president, Professor Bala Audu. Sir, you are on his NOC in pool paraphernalia. You are welcome, and sir,
welcome, sir.
Come to the high table and
Why
others
the
enjoy. Sir, yes.
And I know I'm the acting secretary.
The other one is a Euro guy, I know.
So you should tell me that welcome.
No, don't worry, we'll handle that. So, ladies and gentlemen, Katsina people, you are blessed.
We have.
There has never been a time like this when doctors all over the country converge in Katsina.
We have.
And so we will assure you, when we live for the next at least 1 year, there will be drastic reduction in your indices. So just mark my words. By the presence of #1 doctor in the country,
You're welcome, sir.
and all the paraphernalia that he came with, ranging from the Vice President 1, Vice President 2, the Secretary General I learned is in Uruguay attending to an international program, the World Medical Assembly, and the Assistant Secretary General is here with him, National Treasurer, everybody is here, including the Chief of Staff and Protocol is here, at the IPC of Plateau, Dr. Bapigan. You are all welcome. So, ladies and gentlemen, sorry for the brief interruption. It is very necessary because he is our boss. Let me call on Right Honorable Nasiru Yahya Daura, whom we are still waiting for as the chairman of the occasion to give his opening remarks. But I will now call on my president, the MDCAN president, Professor Mohammed Amin Muhammad, to give his welcome remarks. Sir.
Welcome, sir.
Professor Muhammad Amin Muhammad, President, MD Khan 2023-2025 executive year. You are welcome.
You're welcome, sir.
Distinguished members of the high table, may I crave your indulgence to stand on the existing protocol. But I must appreciate our Honorable Commissioner for Health. In our environment, some people are very proud to say they are Dambu Mehawabiu, but our Honorable Commissioner is Dambu plus Dambu, meaning that Mehawa Hudu. This shows that the confidence, the capacity that he has demonstrated to several chief executives of the state. Sir, we appreciate you, and we appreciate you for your coming even before time, which is quite different from the cultures of most of our political leaders. We sincerely appreciate this, and we will not take it for granted. And we appreciate His Excellency for his confidence in you to appoint you to represent him. Thank you very much, sir. All protocols duly observed. My president and our president, Professor Bala Muhammad Audu, and all other distinguished here present. I welcome you to Katsina Dikko, to April NEC 2024. Katsina, as we all know, is the capital of Katsina State, which is in the northwestern Nigeria. It is one of the most historic towns in Nigeria and in the ancient Hausa land. Since the 10th century, Katsina was a significant center for trade. Most importantly, education. One of the most ancient schools in the northern Nigeria is located in Katsina. So it is a center of learning since the 15th century. And since 1903, Katsina saw to the establishment of many schools and introduced a lot of cash crops, which is the main trade at that time. And this has reshaped the economy, not only of Katsina, but the northern Nigeria as a whole. We all remember the cotton belt, for those who have done geography. Today, Katsina State excel in agricultural product, cultural heritage, economic activities, and including trade and manufacturing. And it is renowned for its vibrant traditional cultures, especially domiciled in these two major emirates of Katsina and Daura. This includes a lot of craft. A majority of the musicians that we are proud of in northern Nigeria also take their origin from Katsina. And there are a lot of festivals which reflect the cultures of its diverse population. The National Executive Committee of MDCAN holds every 4 months across Nigeria. And this time around, we are proud to be in Katsina. As far as I can recall, probably for the first time in the history of MDCAN. We are also here to discuss a lot of challenges facing our members, facing our profession, and also the healthcare and medical education industry in Nigeria and beyond. It is in this meeting a lot will be discussed that will shape the future of healthcare delivery and medical education sector in our great nation. The choice of the theme, enhancing national health security, the critical role of MDCAN in promoting equity and innovation in Nigerian economically challenging landscape is a topic that is apt, more especially in the present time when Nigeria was hit, or the healthcare industry is hit with a lot of Japa syndrome. The sub-theme of global perspective on postgraduate medical career development and insight in the global perspectives on postgraduate medical, on managing the PhD fellowship dichotomy in Nigeria. This is something that is also threatening our medical education industry. A choice of erudite medical academics and astute medical educators to discuss these topics will go a long way in shining the light and providing solution to this challenging problem. Katsina is charming, peaceful city, full of interesting sites and local delicacies, such as different types of suya. Is it the suya that is roasted? Is it the suya that is boiled? Is it the suya that we call tenderu? Please ask for how it is done. It is done in a native pot that is dug under the soil, that the whole product of that animal is put at the same time with its, all the ingredient. And the soil or the whole is exposed to intense heat, and that pot is buried. Even the bone will be softer than biscuit. Try it before you leave Katsina. On behalf of the Board of Trustees, NOC, and NEC members of MDCAN, I wish to express our sincere appreciation to the leadership and the entire membership of Katsina for a well-planned hosting of the event and the grand opening despite the current obvious economic challenges. It gives us a lot of hope. The Chief Medical Director of Federal Teaching Hospital, you amazed us yesterday with the edifice that we saw specifically for MDCAN members in your institution. Sir, we remain grateful. We know that this couldn't have happened without your significant input. We appreciate that. If you have not seen that place, please, before you leave Katsina, go there and rest and see how well prepared it is. I appreciate the government of Katsina State, ably led by His Excellency Malam Umaru Dikko Radda, PhD, CON, the Executive Governor of Katsina State, for providing an enabling environment for this NEC to happen in Katsina. We have all seen, we have all witnessed. God bless you all, and I sincerely appreciate your listening.
That is none other than our president, Professor Muhammad Amin Muhammad, who has done justice by delivering his welcome remarks. A slight adjustment in the program will request our #1 doctor in the country, Professor Dr. Bala Audu Muhammad, to come and give his remarks in this NEC meeting happening for the first time in Katsina Dikko 2025. My president, you are welcome to give your remarks. I, for one, will surely follow the advice of my MDCAN president, where he said, you must explore the tenderu, so that in the next 5 years, I will be his size. Thank you very much.
Sorry, while we wait for the NMA president to do that, sir, permit me to recognize the engine room of administration, Federal Teaching Hospital, Katsina. My DA, sir, a very humble man, he has refused to come up. Malam Hamad Aruna Zambuk. Thank you for the right record. Thank you very much, sir. Yes, sir.
The chairman of the occasion, the president, MD Khan, and his executive members, the NOC members of the NMA, my first vice president and all others here present, the MD, Federal Teaching Hospital, Katsina, all other protocols observed, my colleagues, members of MD Khan, the press, ladies and gentlemen. It's always a great pleasure for us within the NMA to associate with all the activities taking place within the MD Khan, because while the NMA represents the umbrella body of all medical professionals registered by the Medical and Dental Council of Nigeria, the MD Khan represents the top echelon intellectuals of the medical profession in this country. They represent our think tank, they represent our trainers, researchers, and the peak of healthcare delivery in this country. The NMA draws a lot of encouragement from the activities that the MD Khan carries out, the foresight, the focus, and the great maturity with which they carry out their deliberations and focus on issues that create quality healthcare and benefit to its members. I want to say that Katsina Dikko 2025 for the NMA also marks a turning point where we'll begin to deliberate on how to do things differently, how to focus our attention on strategic policy planning and creation, strategic policy implementation, and sustainable action plans that ensure that the contribution of medical doctors to healthcare delivery, as well as to the welfare of its members, remains sustainable and unchallenged, and to bring in about internal harmony amongst ourselves and reduce both internal and external wranglings within the profession in association with our interprofessional colleagues and other stakeholders. I wish the MD Khan great deliberations. I know your leadership will also be at the NMA meeting. Amongst the partnership the NMA seeks with the MD Khan, which I've been having discussions with the president, is to have equity within healthnomics, as well as have a way in which all medical doctors who are fully registered and up to date will have comprehensive health coverage using that HMO as the vehicle, so that at the end of the day, we are taking our money back home. Thank you very much.
Ladies and gentlemen, I think number one doctor in the country deserves more applauses. As you can see, the speech came from above. It's not something written, but highly saturated, highly brainy, and cerebral, and with a lot of information. My President, we are very grateful. Permit me, before calling on our guest of, special guest of honor to make his remarks and declare the session open, to recognize and call to the high table another president in our midst, a president of an affiliate of NMA, president of the Medical Women Association of Nigeria, Professor Rosemary. Please come to the high table and add color, add more color to the table, and come and sit beside the MD Khan president. Sir, permit me to call Malam Umar Dikoradda, PhD, CON, the Executive Governor of Katsina State, who is our special guest of honor, to come and deliver his remarks, as well as declare the ceremony open. And this will be done by his able representation by the Honorable Commissioner for Health, Katsina State, in the person of Honorable Musa Adamu Funtua. Sir, you can, I will bring the mic here, there.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم وصلى الله على نبي الكريم. The 001 of the medical, very much on ground, Professor Adamu, the medical and dental consultant, and your management teams, the LOC, Local Organizing Committee. Let me make it in this form. And my permanent secretary here, the gathering of health family generally, all protocol duly observed. Gentlemen, if he thought that if not a matter of wasting time, he wanted to find it, I will not be surprised before we finish, you'll join us here. That's assured that I have from him. So gentlemen, being the privilege given to me as a supervising officer in charge of Ministry of Health in Katsina State, I will wear a very big cap in this very important day. Important in the sense that health is wealth. Wealth is life. But this is another opportunity in the ancient history of Katsina State today. We have a gathering and a momentum of a very, very powerful, important people, important personalities in our state. Firstly, we have the 001 here with another purpose, a team of consultants on dental and medical. To be a consultant is not an easy. To be a doctor is not an easy. So to have this very, very important phase in our mix, in our state, is a very, very important day in our history of Katsina State. So we have remained very grateful. Gentlemen, as we all know, there is a political will in Katsina State under the leadership of His Excellency, the Governor and Chief Executive of Katsina State. Political will in the sense that his aim and objective and the role model and title, the focal policy of the government is building a future, which is, we all know security is one of our major important. We have education, another milestone. We have agriculture, and we have health. So gentlemen, this is Katsina. Katsina State has 34 local government, 361 wards. I believe if you have His Excellency aim and objective is to building a human resource development, trend and retrend. We have an infrastructure very much on ground. Today, I assure this gathering that our younger ones, and team younger ones, and indigenous of Katsina State, they are outside the state. Firstly, from each and every constituency, in order each and every constituency of 361 wards to have a medical person that belong as their representatives, that is from the ground to the top. Our younger ones are outside the country, spending public resources in order to come and be doctors in the future. It's not a matter of today activities, it's we are looking for the future of the state in generally. At the same time, the one that we have very much on ground, we believe in trend and retrend, capacity building. We believe in teamwork, we believe on collaboration, and very much on ground, no matter how you have the important, infrastructure is very important, needed. Today, our target of the building of future, our end objective, is to have a befitting primary health care in 361 wards, which today, from the last year to this year, capital yearly under review. In the last year, we spent about 62,274 million purposely to reach our infrastructure development very much on ground. I assure you, seeing is believing. If you go to we have befitting standard, dialysis center, 100% completion in Katsina State with fully equipped. We have another medical image, a contract of more than 12.something billion with 100% payment, because going to have such kind of machine is not a window shopping. You must go right to have agreement and all that thing. We are waiting. In terms of the structure, it's about 35%. In terms of delivery concept, it's about 70-something%. The remaining 5% is for implement for proper placing in the site. So, gentlemen, and we have another pharmaceutical company, a contract of over 6.something billion, going around with 80%, and we have each and every period constituency. We have upgrading and renovation, upgrading of another primary healthcare into extended general hospital across the state. So, gentlemen, we believe we want to, in fact, to justify the spending of public funds due to the importance of the health sector generally in Katsina State. So, yearly under review, as I'm talking to you, that's the issue of primary health center I'm talking to you. Last year, from last year to this year, we rolled 102, and currently we have another 102. Even last we have another 134 on existing. Our target of 361 remain not more than 5% to fulfill this promise. But not only the hospital, at the ground, at the primary center, to be a comprehensive with the doctors. We engage in employing doctors. Each and every general hospital we advertise, we got the doctors. We make sure the workforce are very much on ground, 100% needed. And the equipment from the ambulance to machine, scanning machine, mobile hospital, are very much on ground. So, gentlemen, we're here for another purpose. At that purpose, but to assure you, all what we are saying, in terms of completion rate of payment, Katsina, we are doing very well. We are doing very well. We always match up with the federal government in order to enhance and make sure that our doctors are very good, are happy with the situation at the moment, so that they can be billed doctors with a proper support and upgrade and renovation. It becomes an order of the day. So, gentlemen, we know we politicians. If you allow me, I will talk. And I will not sit to talk. Because what I'm taking, I have the gut and ability to talk, because I'm speaking the truth. From now on, seeing is believing. Everybody want to see. Our doors are always open. If you go to this side, you see. If you choose anyone, you go and see him for yourself. So, gentlemen, my duty is to represent His Excellency. At the same time, to declare this in very important occasion on the NEC meeting hosted in Katsina State. On behalf of myself, Governor, and the good people of Katsina State, I welcome you all and declare this open. I wish you all the best.
Thank you very much, Honorable Musa Adamu Puntua, Commissioner for Health, Katsina State, who represented the governor in this August occasion, and he has just done that. And we are very glad that you did. Sir, we want to assure you that it is a recognition of the good works that His Excellency Umar Dikko Radda, PhD, that he has been doing, especially to the health sector in Katsina State, that last year in Calabar, during our annual general meeting, he was honored, and he was there in person. And he promised that that same gathering should happen in Katsina next year. And we have honored that gathering, and we have kept track of what he is doing. And the people, our members here, are informing us that he has not relented, and he's even doing more. So we want to assure you that we are collaborators. We will continue to collaborate in order to uplift the health standards of Katsinawan Dikko. If it were by the side, I will add something, but now I'm scared since it's public. Thank you very much for the job well done. At this juncture, I learned that there will be some entertainment by cultural troops. We want to see whether they can compete with the Koroso of Kano. So, cultural troops, please come and have some 5-10 minutes interlude, and our cultural troops, if you are not around, then we'll seize the opportunity for, oh, okay. Go ahead, you are welcome.
Nakana mai girma governor, deputy governor, commissioner lafiya, 001 a bangaren likitoci na Najeriya, ina gaishe da kowa, da sauran manyan baki ina gaishe da kowa da fatan sun zo cikin ƙoshin lafiya. Sunana Halimatu Sulaiman, ni 'yar Cerenci local government, ni 'yar Katsina state ce, ta ɗakin kara kunya gare mu ba dai tsoro ba. Cerenci local government, na zo nan ne domin na miƙa saƙon godiya ta ga kowa akan ƙoƙarin da mai girma gwamna yake yi. Yana raba scholarship ga waɗanda ba su da opportunity din yin karatu, yana ƙara yi akan harkar tsaro, yana raba wa mutane injinan yin markaɗe saboda ya sa mu daina zaman banza. Yana yin ayyuka da dama waɗanda idan na ce ma zan lissafta su za mu iya kwana muna nan ban gama ba saboda ayyukan da yake yi. Daga ƙarshe ina miƙa ta'aziyya ta zuwa ga mai girma gwamna akan rashin mahaifiyar shi da ya yi. Bari Ubangiji Allah ya yi mata ta'aziyya, ya yi mata rahama, ya sa ta huta, amin. For the benefit of those that cannot hear Hausa, welcome to Katsina State. This is Katsina State, home of hospitality, home of love, home of joy. The best food in Katsina State is fura and nono. I hope you take our fry before you leave the state.
madogarar bayinsa, to shi za ya baka bai ma guri ba. See baby ina kira zo, see baby ina kira zo, to kyale muna buga ya fada Allah, don da kin riga cikin ce Allah ba, ga dan Musa yana kira bakinsa ba, ya faru na bari ni ne ne.
Please, let's encourage them with a financial clap. Financial clap, please. Financial clap. Yes. Thank you very much. The cultural troupe from Katsina and Dikko. At least I was about to say the first one was from somewhere, but at least the second one was from his native to here. So thank you very much for that. Before we go to the presentations of the theme, we would like to have some few goodwill messages. First by the Chief Medical Director of the Federal Teaching Hospital, Katsina, in person of Dr. Suleiman, and as well as another goodwill message from President of M1, Sir. We start with the CMD of Federal Teaching Hospital, Katsina. Sir, your goodwill message, sir.
The chairman of this occasion, and the special guest of honor, the Executive Governor of Katsina State, Malan Duko Omar Rada, PhD, ably represented by the Honorable Commissioner of Health. The #1 doctor in Nigeria, the enemy president, Professor Bola Audu, the president of MD Khan, and the president of M1. Please permit me to start on the existing protocols.
Just some slight announcement, please. Our #1 doctor has another engagement right now. They want to catch up. They want to see the traditional ruler here. Please, we'll allow you, with the permission of the representative of His Excellency, for your entourage to go, sir. Thank you very much for your presence, sir. The CMD may wish to continue after their departure. Unfortunately, okay. So I think,
So on behalf of the staff, management, and board of the Federal Teaching Hospital, Katsina, the Federal Teaching Hospital welcomes all consultants, NEC members that are here for this National Executive Council meeting of the MD Khan to Katsina and Dukko 2025. and wishes you fruitful deliberation and hope that the output of your deliberations will be beneficial to our patients and to Nigeria generally. Thank you very much.
Next is also goodwill message from the CMD Medical Director of our new hospital in Daura, Sir Dr. Abdul Majid. Goodwill message, sir.
His Excellency, the Governor of Katsina State, Malam Dr. Umar Dikkorada, ably represented by the Honorable Commissioner of Health, Malam Musa Adamu Funtua, the Permanent Secretary, State Ministry of Health, Chief Medical Director, Federal Teaching Hospital, Katsina, MD Khan President, Professor Aminu, other members of the high table, distinguished ladies and gentlemen, it's my sincere gratitude and appreciation to be among the midst of colleagues today for this important meeting of MD Khan. MD Khan, as we all know, is the top echelon association of the Nigerian Medical Association, where you have not only trainers but researchers in the field of medicine in our various tertiary hospitals and secondary care hospitals. Today's gathering is an important one, being the first in Katsina State, the home of hospitality. I wish all of us successful deliberations and fruitful outcomes. I also wish us Allah's guidance and safe journey back to our various destinations. Thank you very much.
Thank you very much, the Medical Director, Professor Abdul Majid Sir. Next is the theme presentation on enhancing national health security, the critical role of medical and dental consultants in promoting equity and innovation in Nigeria's economically challenging landscape. And this will be delivered by none other than Dr. Shamsuddin Yahya, who happens to be the Executive Secretary of the Katsina State Primary Healthcare Agency. Sir, you are welcome to the podium to deliver your address. Your address, sir.
Just a
IT.
minute. His citation will be read by Dr. Damusa.
So Dr. Damusa should come forward to read the citation of our guest speaker, Dr. Shamsuddin Yahya.
Dr. Damusa.
If he's not close by.
He's here, he's here.
All right. Quick.
The chairman of the occasion, please permit me to align myself with the established protocol as I read the citation of my boss, the Executive Secretary of Katsina State Primary Healthcare Agency, as well as the guest speaker for this occasion. Dr. Shamsuddin Yahya is an epitome of humility, a leader by excellence, and a very stern disciplinarian and distinguished academic. He's a highly accomplished medical doctor and a public health physician with distinguished career encompassing clinical practice, public health leadership, health policy formulation, and impactful academic research. He obtained MBBS degree from the prestigious Ahmadu Bello University Zaria in the year 2003. And after completing internship program and the mandatory National Youth Service in 2004 and 2005 respectively, his medical sojourn began in the year 2006 when he was appointed medical officer by the Hospital Services Management Board of Katsina State. Demonstrating rapid professional growth, he advanced to senior medical officer and later held the pivotal role of medical officer in charge, General Hospital Remy in Katsina State. And in the year 2009, his commitment to public health led him to pursue residency training in community medicine at Ahmadu Bello University Teaching Hospital Zaria. And after undergoing rigorous training, he obtained a fellowship of the West African College of Physicians in public health in 2014. He obtained a master's degree in health economics from Bayero University, Kano, and a PhD in public health with specialization in health economics and healthcare financing from Universidad Central Nicaragua. This is a testimony to his insatiable desire for knowledge. His dedication to continuous learning is evident in his acquisition of multiple professional certificates, including monitoring and evaluation of public health programs obtained from ABU Zaria, performance-based financing obtained in Kenya, project management in global health, University of Washington, and certificate in leadership management and governance for health system strengthening obtained from Amref University, Nairobi, Kenya. His expertise led to his appointment as a consultant public health physician by the Katsina State Hospital Services Management Board and served in several crucial strategic capacities within the Ministry of Health, including being the pioneer director of malaria and sickle cell disease, director of public health, director of primary health care at the State Primary Health Care Agency, and then later, and currently, the executive secretary of the same agency, a role he was first appointed in 2018 by the Masari administration, reappointed for a second term in December 2022. He maintains a strong presence in academic and professional spheres. At present, he's a senior lecturer in the Department of Community Medicine, College of Medicine, Umar Musa Yar'Adua University, and also contributed to scholarly discourse as the deputy editor of the Annals of Nigerian Medicine, and holds the prestigious membership and fellowship in various professional organizations, namely Association of Public Health Physicians of Nigeria, Medical and Dental Consultants Association of Nigeria, MDCAN, Chartered Institute of Health Economists, USA, where he's a fellow, and then African Institute of Public Health Professionals, where he serves as a fellow too. As a principal researcher, he spearheaded numerous research projects and has had impressive publications, record over 30 articles in both national and international high-impact peer-reviewed journals. And in this current administration, his expertise continues to be highly valued as he was appointed member of the Katsina State Health Sector Reform Committee, where he played a pivotal role in the development of a comprehensive health sector needs assessment and a 4-year health strategic plan upon which the state government is conducting significant health sector reform projects and making impact. He is happily married to a consultant ophthalmologist and is blessed with 4 children. So, esteemed ladies and gentlemen, I present to you Dr. Shamsuddin Yahaya, our guest speaker for the day. Thank you very much.
Consultants Association NEC meeting in Katsina with the theme, the critical role of medical and dental consultants in promoting equity and innovation in Nigeria's economically challenged landscape. I'm going to follow this outline. I will give a little bit of introduction overview of Nigeria's economic challenges, its impact on health system, role of consultants in this landscape, challenges, way forward, and I'm going to cite some few examples of innovations that are currently being implemented in Katsina State, some of which a little have been mentioned by the Honorable Commissioner. So, when we talk about equity, we talk about fairness in access, quality and health outcomes for all populations. So, equity is about fairness, it's about justice, it's about having health outcomes, quality health outcomes for all populations, male, female, young and old, rich and poor. And equity is about removing barriers, poverty, discrimination, geography, gender that keep people from accessing the care they need. And when we talked about innovation, innovation is about having new ideas, practices, or technologies that solve problems and improve health services, especially in resource-limited settings like where we are. It's a known fact that Nigeria is Africa's most populous country and one of the largest economies, but we all know that we are currently facing significant economic challenges. We have high inflation rates. We know that we go to the market, we know how it is. Drugs, I'm sure for many of us here, it's been a challenge. When you compare 2 years ago to now, the drugs that you prescribe to your patients, when you compare the prices from 2 years ago and now, and even the issue of fuel. 2 years ago, I know a liter goes for about 200 naira. Now it ranges between 800 to 1,000. So we have very high inflation rates. We have very high rising unemployment, underemployment, and brain drain. Anytime there's going to be an employment, formal or informal, it's like a tug of war. You know, some positions are not even advertised because of the pressure that comes with unemployment. Brain drain, of course, just some couple of weeks back, the minister had made a pronouncement about the number of doctors that left the shores of this country in the last 4 years, which is quite alarming. We also have widening poverty gap, as over 63% of Nigerians are multidimensionally poor. This number is huge and humongous. When you talk about multidimensional poor, you are not just talking about income. Maybe somebody is poverty in income. You also look at poverty in accessing healthcare, poverty in housing, poverty in shelter, and other social determinants of health. So this number has a lot of implication for the health and well-being of Nigerians, with 63% of Nigerians, and this is as recent as 2022. We also have weak public health financing, as health sector allocation remains far below the Abuja Declaration. The target is 15% of national budget should be allocated to health. But the reality is there are so many other competing priorities, especially around this area where we have a lot of insecurity. Insecurity is taking a lot of chunk of the budget. So, you know, to prioritize becomes a very big problem. I would like to give some definition of terms. When we talk about health equity, It means that everyone has a fair and just opportunity to attain their highest level of health. And for some people, it becomes a little bit confusing when you compare equity and equality. Equality gives everyone the same resources, while equity allocates resources based on needs. So we all have different needs and wants, and the ideal is to have equity because people have different needs. So, and innovation refers to new or improved ways of thinking, organizing, delivering or financing healthcare that are effective and sustainable. The world is fast changing, a lot of innovations, a lot of coming up. So it's very important that we should not be left behind. We should move with the tide. So in terms of innovation, we can look at service delivery innovations, e.g. tax shifting to community health workers, mobile clinics. These are some of the service delivery innovations, just to address some of the gaps we have in terms of service delivery. Process innovations, example, streamlined referral systems, our e-records, automated drug inventory. All these are process innovations. Then we have technological innovations, the telemedicine, AI in diagnostics, mobile health platforms. These are all examples of innovations. So when you talk about equity and innovation, it's like you have the two sides of a coin. One is as important as the other and complementing the other side. When you look at the aspect of access to care, you know, when we talk about access, we talk about geographical access, financial access, sociocultural access, and others. So how innovation drives health equity is when you have telemedicine, mobile clinics, and e-health expand reach to rural and undeserved areas. When you have these innovations, it helps you to reach out people in the hard-to-reach areas because of the need to have access. On the other side, how health equity drives innovation, because of the demand for inclusive access drives development of low-cost, decentralized care models. A lot of models have evolved over time so as to make sure that we have access to healthcare for all. Affordability. Digital health tools and AI reduce diagnostic and treatment costs, which makes it affordable. This is an innovation. A lot of innovations are coming on board. And when you look at how equity drives innovation, you focus on affordability, promotes frugal and locally adaptable health tech solutions. Example, zipline technology. This is one innovation that is being piloted in, I know it's in River State, and for Katsina State, we are also considering adopting this technology where you have, you use drones and other medical equipments to deliver some key health commodities, for example, vaccines, blood and others to very remote areas where you cannot reach, especially maybe during rainy season where you have had to reach locations due to flooding and others. You'll be able to deliver those kind of interventions, or where we have insecurity. This will also provide opportunity to deliver these services. Health information, how innovation drives health information. You have mHealth, you have a lot of applications, SMS campaigns, improve health literacy in low resource settings. So this is how innovation drives health equity in terms of health information. And on the other side, equity pushes innovations towards multilingual, culturally sensitive communication tools, because you want to make sure that you reach everybody. You use these apps in local languages so that majority of people can be reached. Workforce support, digital platforms train and support community health workers remotely. This is one area we are also piloting in Katsina State, whereby we are planning to train over 2,000 frontline health workers. I'm going to talk about it later. Then we have data for decision making. Health information system identify disparities and guide equitable policy. And on the other side of the coin, equity needs drive innovation in real-time disaggregated health data collection tools. This is to ensure that we have data for decision making. So coming to the main issue, what is the role of medical consultants in equity and innovation landscape? As medical and dental consultants, we know that we are pillars of the health system, not only for clinical expertise that medical and dental consultants have, but also their authority, mentorship, and ability to influence the healthcare system. As we know, the health building blocks of the health system, one of which is human resource for health. And when you are looking at the pyramid, the consultants stand on top of the pyramid because of their expertise, their experience, and generally their authority. So this is very, very important role that as consultants we need to play. In an economically challenged landscape as it is obtained in Nigeria, the roles extend far beyond the consulting room. We need to start thinking, even if you are within the clinical setting, we have to take charge. We need to make sure that our influence goes beyond the consulting rooms. We need to influence policy, just like O1 has said. We need to do a lot more to ensure that our presence is felt. As innovators, role of medical consultants. Medical consultants lead in clinical trials, designing context-sensitive protocols. This is very apt and very important role. And as equity advocates, ensuring no one is left behind in policy decisions. Whatever is going to be designed and implemented, we need to make sure that the marginalized are also taken care of, so that we'll be able to have equity in healthcare. And as mentors, this is our traditional role, teaching younger professionals how to embrace equity and innovation in healthcare delivery. This is also a very crucial role of medical consultants. Clinical leadership, setting standards for patient care and mentoring junior doctors as well as medical students is also another very important crucial role of medical consultants, as well as advocating for evidence-based patient-centered models. We need to often participate in hospital management boards, quality assurance, and clinical governance. We need to make sure that our voice are heard. We take lead in making sure that the health system is strengthened. Also, as advocacy and in terms of advocacy and equity, consultants as voices for marginalized population, the children, elderly, poor, and disabled. And we also have to inculcate promoting inclusive health programs. When we are designing health programs, we don't just think of those that come to us in our hospital settings. We need to start thinking of how do we reach others in terms of outreach clinics, use of technology to remotely to provide healthcare delivery, that's telemedicine, community health insurance. These are all roles that need to be played by consultants. As consultants, we need to be innovation champions. Consultants driving clinical research and digital health solution, promoting local innovations. Sometimes we need to think outside the box, come up with indigenous knowledge, low-cost diagnostic and treatment protocols, looking at the setting we are in, and we need to make sure that we come up with innovative strategies to address issues within our localities. What is a problem in, let's say, Lagos State may be different from what is in Katsina State. So we need to start thinking of how to come up with useful, innovative strategies to address some of these things. And other example is tool to manage chronic disease in rural areas. Still on the role of medical consultants, innovation potential, a resource limited setting. So despite the myriads of challenges Nigeria has immense untapped potential. We have a growing digital ecosystem, high mobile penetration, health tech startups. A lot of people in the last NBS survey, a lot of Nigerians own mobile phones, and so this is an opportunity for us to tap from. We have young workforce eager for mentorship and innovation in healthcare. We need to be discussing on policy reforms like National Health Insurance Authority, NHIA Act. This for us to achieve universal health coverage, we need to make sure that we contribute in the policy reforms like the NHIA Act. In terms of policy engagement, which like I've said, the O1 has talked about, work with government to create equitable health financing system. A lot of reforms have been ongoing, so we need to make sure that we are at the driver's seat. We need to push for legislation that support local innovation and access. There is need to also expand training in leadership, health economics, and digital tools for consultants. When you look critically, all the leadership of our tertiary hospitals, for you to become CMD or MD, you must be a medical consultant. So we need to acquire the basic skills in leadership and digital tools. This is very important to keep up with the, improving changes in the world we are. And we need to support young professionals in innovation pathways. It's very important for us to collaborate with academia, tech startups, NGOs, and donor agencies. For us, because we collaborate and we work with a lot of NGOs and donor agencies, once you have a very good idea and innovation, and you are willing to apply for grant, you'll be able to get a lot of support so that you'll be able to actualize your dream. We also need to harness, we have a lot of our colleagues in the diaspora, so that we'll be able to foster better strategic partnership with them for us to achieve this innovation. As consultants, we need to strengthen community-based interventions, like consultants leading mobile health missions, community outreach, and health education campaigns. Even yesterday, there was a similar campaign, though by NMA on medical outreach, and it's still ongoing. So as consultants, we need to lead the way so that marginalized groups, people that are not that are poor, as I've said, 63% of Nigerians are multidimensionally poor. So any time in design and conceptualization of implementation programs, we need to put this into consideration. So while we have enumerated the various roles consultants are supposed to take in order to actualize this to actualize the dream of having innovation and addressing equity gaps in Nigerian setting, where we have a lot of economic challenges. We need to look at a lot of challenges we are facing. While consultants are expected to be at the forefront of equity and innovation, the environment they operate often poses serious challenges. These barriers are both systemic and structural and must be acknowledged as we seek a solution to these challenges. Number one of the challenges is inadequate infrastructure and resources. Many tertiary and secondary health facilities lack basic equipment, consumables and utilities. Consultants often work without functioning diagnostic tools, ICU support, or reliable power supply. This limits the quality of care and stifles innovation, as even the best ideas can't thrive without tools. This is very true in most of our tertiary and secondary and even the primary healthcare facilities. So a lot of inadequate infrastructure, is one of a key challenge. Bureaucratic and weak health governance, policy bottlenecks, poor procurement systems, and centralization slow down decision making. When you want to everything, instead of decentralizing, but you want to centralize, you want to do something innovative, you have to wait. Perhaps maybe it has to come from the at the level of the federal government, and you are operating at a state. So this slows down decision making, and it can become a challenge. Administrative red tape can frustrate consultants who want to implement changes. Lack of autonomy in public hospitals discourages initiative and accountability. Poor funding for research and innovation. Research grants are limited and highly competitive. Many innovative ideas die at the proposal stage due to lack of seed funding or institutional support. And Nigeria invests less than 1% of its GDP in research, which is well below the global average. How do we expect homegrown solutions when our system does not fund the science behind them? So for us to make headway, we need to invest heavily in the research. That is why advanced countries like US and Europe, they invest a lot of money in terms of to make sure that they keep abreast with the happenings in the country. Consultant burnout and workforce exodus. Heavy workload, poor remuneration, and lack of appreciation lead to physical and emotional exhaustion. Some people are laughing. Maybe this is very clear. Many consultants have emigrated in search of better conditions, worsening the brain drain. Those who stay are overburdened, often playing multiple roles: clinicians, administrator, teacher, mentor. So just before I came up, I was discussing with the MD FMC. I showed him that we are discussing about the shortage of human resource, and I just showed him that some people are coming to recruit our consultants, and if care is not taken, many of the people here will succumb to that and move to greener pastures. So this is the reality that is happening. We are wearing too many hats with too little support. Even the most committed consultants can burn out. So that is the reality on ground. Insecurity and regional instability. Consultants working in the Northeast, Northwest, and other insecure regions face constant threats to safety. This is also one great challenge we are having. For us, issue of kidnapping, banditry, and attacks on health facilities limit outreach, mentorship, and retention of specialists. We've had cause to close down facilities due to these issues of insecurity. We also have as a challenge limited digital infrastructure, poor internet access, a lack of IT infrastructure restrict the adoption of digital health solutions. Many hospitals don't have electronic medical records, which hampers data-driven decision. Cultural and systemic resistance to change. Yes, some institutional cultures are resistant to innovation, seeing new ideas as threat to the status quo. I think we need to work on that. We need to be open-minded and allow, new ideas to thrive. We shouldn't just remain with the status quo. We need to make sure that whatever we do, we should move with the tide. Young consultants may find their ideas blocked by traditional hierarchies or professional politics. So this is also a challenge. So after highlighting all these numerous challenges, what is the way forward. So despite the myriads of challenges, Nigeria's healthcare landscape also presents enormous opportunity for consultants to make a difference. The key is strategic action moving from awareness to implementation, policy engagement and leadership. Consultants must move from the sidelines into active participation in policy making. At institutional, state and national levels, consultants should be part of technical working groups, health boards and reform committees. As consultants, we should be able to push for policies that promote equitable distribution of resources, support for local innovation, improved working conditions and remunerations. If we are not at the table, we are likely on the menu. So consultants must shape policy, not just respond to it. This is very important. Capacity building and knowledge transfer. We need to organize and participate in trainings on leadership and health system management, digital health and telemedicine, health economics and finance is very, very important. We should be at the driver's seat, and regardless of whatever profession you are, your discipline, you should have the basic knowledge and skills in terms of leadership and health system management. We should create platforms to mentor junior doctors and medical students in innovation, ethics, and equity. Community-based interventions, lead consultants-driven programs in rural and underserved areas, not just for us community physicians, but for all others. Whether you are pediatrician, you are obs and gynae, you should be part of these regular outreach clinics, preventive health education, non-communicable disease screening, and early detection. We need to collaborate with local leaders and CSOs to build trust and alignment. Strategic partnership, I will round off. Okay. We need to set up internal innovation labs or idea incubators in teaching hospitals and other facilities. We need to promote low-cost, context-specific innovations like locally fabricated diagnostic tools, community paramedic models. We need to leverage on digital tools, engage with health financing reforms. Let me just quickly, last part of my presentation, to say a few things that Katsina State is doing in terms of innovation to address equity. So this is in effort to transform health insurance through digital innovation. We have Katsina State Contribute to Health Management Agency. They introduced self-service enrollment portal, where you can have easy online access for individuals and organizations, real-time enrollment and updates, and seamless user experience. The impact is over 415,000 enrollees across formal and informal sector have been enrolled into the sector. Then online health care provider registration, which is simple, fast, and secure online empowerment process. And the impact is more than 170 primary and secondary health facilities registered and empaneled. Service automation and robust claim management, expanded access to essential services. All these innovations to address equity and improve access to healthcare delivery. For us in the State Primary Care Agency, some examples of what we do in terms of innovation. We have introduced the biometric attendance system, whereby we use machines. Our staff clock in and out. When you come in the morning, you log in. We use fingerprints or Face ID to clock in. When it's time for you to go, you clock out. We also use that machine to look at the output of what you do in terms of, we have our key performance indicators, ANC, routine immunization, and what have you. We have also pioneered what we call MCH Track, which is a technology-driven system to effectively track defaulters for routine immunization and ANC attendance. We use an app when we have VCMs, voluntary community mobilizers. They mobilize women to the facility. When they go to the facility, they are enrolled, and the app will automatically update their next schedule of RI or ANC, and 2 days to the time, it will send reminder to the VCMs, and they go and contact those women and children to to go for their next follow-up visit. We have pioneered the Enhanced Resilience in Community Healthcare project, which is a utilization of an adaptable digital solution using mobile phones to provide standardized professional development, support, and resource to health workers in remote and low bandwidth areas. So we are targeting over 2,000 healthcare workers, frontline healthcare workers in the villages to support them in terms of capacity. We also have EHA clinics. This is a digitalized care process and use advanced data analytics and artificial intelligence to improve health outcomes, reduce costs, and bringing life-saving services closer to the people who need them most. We have just signed MOU with this, with the eHealth Africa, who have this, and we are going to pilot it in at least 3 or 4 clinics. For HSMB, I know we have electronic health record in 7 pilot hospitals and 2 specialist hospitals. They are also piloting biometric data attenders. This picture shows, this is last week, Tuesday, signing MOU with EHA clinics to digitalize care process and new advanced data analytics and AI to improve health outcomes. This is His Excellency, the Governor, and the Honorable Commissioner, myself, and Chief of Staff, and the representative of EH Africa. So just to show you how we take our innovations seriously. Again, this is training of PhD workers on the use and operation of biometric data capturing machine. This is the machine, and these are our staff that we have trained. And currently we have deployed 34 machines, 1 per LGA, to ensure that we track attenders. This is a flow chart for generating mortality data through the Katsina CBHMIS and IDSR project. This is also, we do verbal autopsy and as well PCVA, physician certified verbal autopsy, using technology. We have reviewed over 10,000 mortality in the last 2 years, and working on it to ensure that we inform policy about especially maternal and neonatal mortality. This is, I think this picture was taken yesterday. Outbreak response to circulating vaccine, the polio virus. This Batsari is one of our facilities that has security challenge. If you look at the second picture, you see me with some people. We have some of those places, if you want to go in, you have to go with some vigilantes that have, you can see them welding some shotguns for you to have access to those places. Thank you very much.
Thank you very much, sir. Thank you very much. It's always nice listening to Dr. Shamsuddin. We thank you most sincerely, sir. Except for time, we would have allowed a few comments. Do we have any comments? If we don't have one, can we all please? Okay, no comments. Can we please appreciate Dr. Shamsuddin Yara? Thank you very much, sir. Yes. Yes, I know. I know.
Yes. Thank you very much, our theme speaker, Dr. Shamsuddin, for doing justice to the topic at this juncture because of exigencies of the office of the governor and that of the Honorable Commissioner of Health, who has been with us for almost 3 hours plus. So we are very much grateful.
Thank you very much.
And we understand that you are about to take your leave. We appreciate you, and we are still going to stay behind even after the NEC to continue with the NMA activities. And we'll enjoy the good atmosphere and everything about Katsina. Yeah. And I said, they said if you spend more than 7 days, they will add one wife to you for those without 4. Thank you, sir.
Thank you very much, sir. You are welcome.
So they will escort him. LOC should come forward because we are going to arrange this. The next thing is the panel discussion. And we know panel. Oh, are you comfortable with this arrangement?
Oh, baby, let's bring the chairs here.
Panel discussion.
Hey.
Chairs. No, that no put chairs. For musculoskeletal health, please exercise your joints, especially those of the lower limbs, including the spine. Yes.
Bari mu. Have we introduced them? Ba ka fi san su ba? Ka fi san su. Good afternoon, all. Now, we're there to a very, very important session now. We are going to have a panel discussion. I'm happy. I don't know whether we have sold out or whether I have to put in for it. But we have teachers, eminent scholars that will guide us. It's going to be a very, very interesting session. And I hope at the end of the day they are going to answer some questions that we have. It wasn't easy for me to do residency, to have fellowship. Now they say I must have PhD. I don't know whether the panelists, they are skewed, but I will not say anything until the end of the whole discussion. To us to discuss global perspectives on postgraduate medical career development and insight into managing the PhD fellowship dichotomy in Nigeria, we have a panel of experts. Many of them are my fathers. Dennis, Mr. Dennis, it's better you do this because whatever I say, they can still withdraw my fellowship and stop my salary. They are my examiners. It's such a very difficult task you have given me. But I know they are going to forgive me, sir. First, now I'm going to introduce my father in the profession, Professor Sani Balarabe Garko, Professor of Cardiology, MNI, PhD. Isn't it, sir? Yes, sir. And next to him is Professor Aliu Abdu. Professor Aliu Abdu, my mentor, my teacher, my supervisor, a professor of nephrology. I think you are the current either provost or registrar is a provost of a medical school. You may have kids that want to join medical school. You are welcome to Katsina, sir. And for Professor Yaya, I learned polio like never before. I was shocked the lecture he gave on polio. As if I've never heard anything about polio in my life. That polio you gave, even though I was in Guru, I joined you by Zoom, I've learned a lot of polio from him. If that's the only thing I know, they will pay me salary in FTH Katsina. Professor Yaya is a professor of epidemiology, he's a pathologist, a microbiologist. You are welcome. I think that I should have PhD too. So if you have a skilled audience, I really don't know where to start with. Dr. Garba, you are still young. Whether they will tell us to go and do PhD. In any case, I'm at the bar. I've left everything to my children. But this is a very, very important discussion. You want to know, before fellowship used to be very, very attractive. I know what I went to with Professor Samaila just to get fellowship at West African College. And now PhD has come in and we are being relegated. And they have told us that by 2026, we may not be professors again. And that is quite worrying to me. Now, to moderate and to give us insight is Professor Sani Balaraba Garko, MNI, sir. Yes. Thank you very much, sir.
Thank you very much, members of MDCAN, the national president, and others. As you have heard in the introduction, they say I have a PhD. Actually, I have two. So I'm not the best person to moderate. So we picked Aliu Audu to moderate so that when we swear, he will bring us back to line. Yes, so with your permission, the organizers, Professor Aliu Audu will moderate this session. And we understand we have 45 minutes. We will try as much as possible to be within that time frame. The most important thing is we just want to reevaluate our stand as MDCAN on the PhD and fellowship saga. Thank you, Professor Aliu Audu. Go ahead.
Okay, thank you very much, Professor Garko. And I want to thank the organizers
fellowship going together or one preceding another. It is something new in Nigerian medical education system. We need to go back to history. Maybe Professor Yahya, do you want to add anything?
Thank you, Mr. Chairman, and thank you, my fellow Katsinawa and our guests. I'm happy to be back home. I take mentorship after my teacher, Professor Sani Balagarko. Just to inform you that I do not have a PhD yet. I have 2 fellowships, Fellowship of National and also West Africa, but I'm registered for 3 PhDs. One is a Doctor of Public Health, another one is a Doctor of Science, and then the third one is a Doctor of Philosophy. I want to follow my mentor who has 2. Now, to take us back to history, PhD before the independence, let us look at regulatory frameworks that we have in this country. The National or the Nigerian University Commission, NUC, has been in existence since in 1962, but it was an advisory commission. It wasn't until the 70s, late 70s, that it was formally given the mandate to regulate degree awarding institutions in the country. Now, when we look at our fellowship on the other hand, the National Postgraduate Medical College of Nigeria was created by an act in the 1976, while the West African College of Surgeons was the one that we had as the initial college since in the 60s, 1962, while the College of Physicians came much later in 1968. Now, taking us back to history, looking at the foundation fellows, most of them did not go through the same fellowship like we did. They were awarded based on experience, based on expertise, and some of them they were trained abroad. And most of them, when they were coming back with fellowship of the Royal College and a PhD. I know this because I went through personal record of most of them, and I have seen. I do not want to call individual names. I know my mentors in Ibadan, they have MD. Some of them have Doctor of Science. Some of them have PhD. And some of them have Doctor of Public Health. How did we lose it along the way? Now, when they came back, the PhD component was not strengthened. Every institution from Ahmadu Bello University to University of Ibadan, there is an MD program in existence. It is just dormant. An MD that has been vetted and approved by the University Senate. But then along the way, it was relaxed. People ignored that component and concentrated on the residency because of the importance of the residency. I'm not relegating the importance of residency in any way. Residency is very important. That is what will give you the clinical skills to practice, and that is what, if you look at the top researchers in Nigeria, go and check, we know ourselves, go and check ResearchGate, Google Scholar, everywhere. The top medical researchers in Nigeria have fellowship and not PhD. But what happened along the way? In the 70s, it was flourishing. But in the 80s, they had a similar economic downturn, just like we are having now. And most of them japa out of the country. So that component was not strengthened, and we lost the faculty that can train the future generation of doctors. So to me, it's not a new phenomenon. It's actually an old phenomenon that was relegated.
Okay, thank you very much. Maybe I'll add on to that. Probably, see, the problem is that most of the pioneers that had a PhD, this one is not loud.
You put it closer to you.
Hello? I have to put it very close. Okay. Most of the pioneer elders that we have, when they came back, they had a PhD done. Having studied the system where they trained, when they came back, they were supposed to emphasize a system that will live long. But I think because the doctor has this feeling of own important best student from primary school. Is there any best student in primary school? I think there is also best student there, but primary, secondary. So they feel that because they are MBBS, they don't need to emphasize the PhD component. So they now stressed on residency training, which, if you look at it in contemporary world, fellowship of any postgraduate school of medicine is actually an award. It's not by exam.
And the National College, at its inception, was licensed to award degrees. National College would have awarded PhDs, would have awarded MScs. But in their wisdom, they chose not to emphasize the degree aspect. They emphasize on the certificate. In fact, they call it diploma. That's the other terrible part of it that they accepted. They call it a diploma. After all the suffering, traveling to Lagos, Ibadan, they give you a diploma and they said that that is a degree. That's not a degree. Because today, if you apply to any institution, anywhere outside, you write MBBS, Fellowship National, Fellowship of Africa, your letter will come out as highest degree is MBBS. They won't recognize it.
Okay, as the interest of time.
Yes, exactly.
Then
so they didn't do that, and unfortunately, they are now the chief principal advisors to NUC. If you are talking to the NUC, they will tell you they have discussed with Professor X, Professor Y. They say all of them had PhD. So that was the greatest blunder they did for us. Thank you.
Okay, thank you for taking us back to history. But now that in the last few years we entered into this quagmire of fellowship versus PhD thing, where are we now? Is it a win or a loss to consultants in Nigeria? Maybe I'll start with Garko this time.
Well, I would say it's a win-win. Quoting a famous politician from Kano, win for us in the sense that we've been awoken painfully about the mistakes and the blunders committed by the arrogance. You know, a medical doctor, when somebody has knowledge and money, arrogance follows. Is that arrogance of knowledge that made them to think that we don't need a PhD. By the time you go through the PG training, you have had it all. So we are painfully awoken to that fact that our elders committed. And win for the system is that the NUC is a regulatory body. When I was MDCAN president, the NUC insisted there must be PhD before you get promoted.
I will come to the MD.
Okay, fine.
So just let's
okay, fine.
Is it a
So
win or a loss?
Win-win. Or we'll just leave it at that.
Win-win. Okay.
Okay, so before I answer this question, I will give us a background quickly. Two things. Number one, there are stages of grief, 5 stages of grief. The first one is called denial. When something happened to you, you deny it. The next stage is you become angry. And then the next stage is what? What's the next stage? Denial, angry, and then you become depressed. And then bargaining. Bargaining is the next stage. And then you become depressed. And then the last stage is acceptance. Now let me take us to another issue again, team building. In team building, once you come, different people, you want to build a team. The first thing that will come is suspicion. You have stages in team building you have a successful team. You have the forming stage, the norming stage, and the storming stage, and finally the performing stage. When you each of you have understood the weaknesses and strengths and the opportunities you can maximize by working together. A striker can never be a goalkeeper. Likewise, a midfielder can never be a striker. You need to support each other to achieve your goal. Now, to answer the question, I didn't see it as a battle. I see it as a stage of team performing or a stage of grief that we actually went through. But I still concur with my teacher that we didn't lose anything because to start with, it wasn't a battle. Thank you.
Okay, thank you very much, my colleagues. So to you also it's a win-win or or consultant lost?
Yes, no, we won.
Okay, we won. Okay.
But it was never a battle.
Okay, because what is going on now, we are seeing proliferation of degree awarding programs in most of the universities. Started with Calabar, Sokoto, everywhere. Yeah, they are mounting PhD and this thing. So that takes me to the next one. What have the struggles of the MD-CAN been? I think Garko also started with this one. You are a past president of the MD-CAN. So what has been the struggles of MD-CAN in this PhD fellowship thing?
Well, you know, MD-CAN opposed it. It never agreed. Maybe the grip stage, like he said. And unfortunately, within the fold of MD-CAN, we also have some of the remains of the elder people, those who were part of the issue, that initially benefited from going to do a PhD and then come back to advise the NUC. So each time NUC calls a meeting, they will bring one old man who was your great-grand teacher and sit him down there to be looking at you while you are talking. But at a point, MD Khan, I know, told the NUC that doing a PhD for anybody who could read medicine is not a big deal at all. In fact, personally, I promised the NUC executive secretary I would do 5 PhDs for him, and I'll bring it, and I'll not go on leave. I will do them while I'm working. Yes. And I started. I did 1, 2. He said, this boy, are you serious? You are a crazy guy. I said, yes, sir. Because if you are able to read medicine, there is nothing. No. The only problem is that some of us have aged. When you are a senior register, how many PhD will you do? You can do 10 in 2 years. You know? So it's not a big deal. So MD Khan had always gone against it, but then, you see, realizing the fact that NUC is a statutory body that regulates education in Nigeria, you cannot fight against it. I'll give you an example. This man that has Berekete radio, he was all over the place. I think carried away by his popularity. You know the crowd, they can cheer you to death. Oh. Hey, go on, you are shouting, and then you just enter fire. So he was actually carried away, and now he's nowhere. They have arrested him, they have kept him somewhere. You're not hearing of him. So you see, we didn't want to go head on with the government. We had to accept. NUC could regulate, but we tell them, for medical education, you cannot decide who teaches. You allow it to the Committee of Provost and the universities to decide because they are autonomous. Okay, so I think that's what I was saying.
Okay, Professor.
Yes, just to give my perspective, I am not as experienced as Professor Garuko, my teacher, but one thing that is constant in life, and one thing that does not change. Everything changes in life, everything, except change. So change is the only thing that does not change. Take a moment and listen to this statement again. So we need to evolve, we need to outmaneuver, we need to outcompete our other professionals that are in the sector working with us. Why? To improve health outcome, to improve patient outcome. Every profession in the country, the last one standing was medicine. Lawyers went through a similar thing. Initially, it was their LLB and then the BL. They don't do most of this PhD, and they can progress up to professorship. But they went through a similar thing, and eventually they realized that they need to change, they need to evolve, and they need to adapt. That is the only way you can survive. Now, if you remember Darwin, Charles Darwin, remember the survival. For you to survive, you need to adapt. We are in a changing environment. There are global competitions emerging. Which one? I don't want us to start which one is superior, which one is inferior. Clinical fellowship is very important, and we must do everything in our life to protect it, to make sure that the profession survives. But you need the clinical PhD. You need the academic PhD, because it will give you another perspective of life. It will open other doors for you. I have applied for grants that I was denied simply because I do not possess a PhD. So if someone will tell you, we are talking about global perspective, you should not think local. I was denied a grant because I do not possess a PhD, and I could not proceed. And it was a grant that I could have easily won into millions of dollars, and a competitor was able to win. It's a disadvantage to me because I could get a PhD. I was also denied an opportunity to sit in an international organization job in Geneva simply because I do not have a PhD. I have met all the qualification metrics, looking at publications, looking at research experience, but I do not have a PhD,
Okay,
which
Professor,
denied me with that opportunity.
I had a plan to discuss, to share experiences, but you have already gone there. So I think, so what is a global perspective? Is it only in Nigeria that this dichotomy happened, or is it something that is seen in other countries, in other parts of the world? So I want experiences. So
well, globally, if you look at it, medical education actually goes 2 or 3 tracks. First track is academic track. where the person gets MBBS and proceed on research. We have them in patchy areas in Nigeria. I know Ibadan, the provost office, has employees as research fellows. Some universities have that. So that's a track that somebody can grow and become a professor on the research track. And then there is hospital track, where somebody specializes, his clinical acumen gets certified by the authorities, and his own experience is based on hospital acumen. And I know that in ABU we had professors based purely on clinical acumen. My teacher, Professor Abengowe, was given professorship based on clinical acumen. Late Professor Bidi Musa also was given professor based on clinical acumen. And he rose to DVC in ABU, actually. So those are the main tracks. In the US, those are the tracks. In Nigeria, we need to also change that to go to that direction so that this confusion needs to be cleared, because it was a confusion, I think, inadvertently. I'm sure they didn't see the future when they opted for just hospital training. Thank you. That's what I would say.
Yeah, just to support what Professor Gorko mentioned, looking at the global perspective and the difference in academic research and clinical pathways. Now, the message from me is that it's not everybody that must do the PhD if you have a fellowship, but then we should have a critical mass. Each of us have our own career trajectory and career path, and that is what is happening in US, especially for NIH-sponsored programs. We have the clinical PhD, MD track, which you start right from the undergraduate till you graduate with the clinical PhD, MD track. And we have other similar scenarios in Australia. We also have in the UK. But what we need to do is to identify and understand what is our pathway for career development. What do we aim to achieve? Not everybody wants to be a professor anyway. And not everybody wants to be a university lecturer. Not everybody wants to be a researcher. So choose your pathway and stick to it.
Okay,
but
I'll
I think
come to
as
way
an
forward.
institution,
So global perspective.
Yeah.
So you think it's nothing new?
Yeah, it's not.
Okay. Okay. Thank you very much. So, what is the way forward? That we shouldn't be working in isolation. Yeah. So, what is the way forward? Maybe I'll start with you, Professor.
What I see as a way forward for us is to understand the global perspective and also contextualize it into our own area. We must respect institution. We have to pay tax. We have to abide by regulation. This is a national regulation. Clinical PhD, clinical fellowship is recognized and is acceptable for career progression in clinical medicine. But it is the decision of the country through the agency it recognized to register, license, and regulate universities that for career pathway is the PhD by a certain date. We can always negotiate that. But we need to imbibe and understand. It's not something we should fight. It's something we should adapt. Scenarios have been mentioned earlier by the chairman. He has mentioned Calabar. He has mentioned University of Port Harcourt. And also I know that I'm part of the people that draft the initial proposal for the clinical PhD in Sokoto, and it is very accessible. There is no department that you can think of internal medicine that we did not design a 2-year program that can be done by correspondence, in quotes, for you. You only need to go to the institution twice for you to depend your proposal and for you to depend your internal defense. Most of the collaboration is between you and supervisors. And you do a research in 2 years and you have PhD. We have mounted it. It has been approved by NUC. You can mount it in your institution and we need to imbibe it. And we also need to integrate this clinical PhD, just like the MD has now been integrated as part of national, so that the generation coming after us will not have to do these dual programs. It will just be integrated. The more we resist, the more it will keep coming. This problem, to my knowledge, Professor Gorko, it started around 2006-07. That was when NUC sent the first letter. And they kept on hammering. It refused to go. So that's the way forward, and that is what I feel we should do, and that's what the MD can should strengthen as an institution.
Okay,
Thank you.
yes,
Thank you. I agree with you in part, but I think the mode you describe will be to mop up the damage that has been done for us. But a younger PhD is less than a fellowship. It's less than part one. So I would want PhD to be done by the younger people, MBBS, PhD. They can do MBBS, PhD at undergraduate or just after graduation. So that by the time you have your PhD, you can now enter residency if you so wish. So sincerely, my own take is we should lobby, especially the federal universities of health sciences and the state universities of health sciences, to mount programs that would enable medical students to graduate with a PhD. All they need additionally 1 year, maybe to do research and publish and defend it, they have their PhD. So that if you want to do residency, you can come for it. Certainly the training is more rigorous, it's more in-depth, and by the time you are a consultant, PhD is way behind. So this one can actually control damage. For those of us that want, we can just take it up and do. But sincerely, after you are a fellow, they started to go to lectures for PhD. I think that's an insult.
Okay.
I don't agree with that. Thank you.
Yeah, I just want to buttress one point that Professor Galko mentioned about, I don't want to rate it because we have colleagues that have PhD, medical doctors that have PhD. The top qualification that I consider in this world is medical doctor, MBBS. I do not aspire to be anything apart from a doctor. So all other things is bonus. Becoming a consultant, becoming a professor, having master, all of it is bonus. So the basic qualification we should all protect is the MBBS. Now, once we do that, we should not try to mock our colleagues that opted for the PhD pathway alone. It is not a good way to build a team. Now, I do not want to rate them, but the entry point, Professor Garko, for PhD is lecturer 2. Lecturer 2 is a step below lecturer 1. While the entry point for fellowship is lecturer 1. I was given lecturer 1 while I was a senior registrar, simply because of my publication and the need for the institution. I was about to go for exam. But when the assessment team looked at my publication, they placed me at the pedestal of a lecturer 1. And that was what prompted my rapid rise in the academia. And we need to understand that part. I just want to portray that part, that lecturer 2, lecturer 1. So you choose your entry points.
So how do you see the initiative by the National College? National College now, they want to make it pre-part 2. Instead of the MD program, they have now set up a committee which reviewed the MD program. Luckily enough, I was part of that committee. So what we did was to review the MD program and present it as PhD. So immediately after your part 1, you choose a pathway. The pathway of going to PhD and fellowship, or the pathway of doing only fellowship. So if after part 1, you register for your PhD with the college, and then your thesis will be assessed for a PhD. And then at pre-part 2, you depend the thesis and be awarded your PhD. And then you come for your part 2, you do just clinical exams, and then you'll be given fellowship. So by the end of the residency training, you get the PhD, you get the fellowship. That is part 1. So this is where we are at National College, and this proposal has been submitted to NUC. I know, so we are waiting for that. So instead of MD is a higher degree, but because of the problem of this country, many other professionals are doing doctor of this, doctor of that. So MD is no longer as fashionable as before. So this one way, Professor Garuku.
Yeah.
The other way is that as a young academician, you need to do a quality research to progress. So what if an opportunity come that you do a quality research and earn a degree and also publish your work? So there's another pathway for a PhD based on research. Based on research. So as a young consultant, you now get your topic you want to research on, area of research, develop your proposal, and then submit it, assess whether it is good enough for a PhD, conduct your research, publish,
a minimum number of papers out of that result you present, and then you giving your PhD. You're already a young fellow. But for the older ones, I don't know whether they will still want to go through this.
No, it's okay.
But
my
talking
only
about
concern, my only concern with that, you see, PhD at the colleges, National College, West African College, my worry is the mindset of the examiners. If you go through a conventional university and do PhD, and you go through a postgraduate program, the mindset of the examiners is completely different. PhD, I told you I never went on leave. I didn't take any. I was still working. I did my PhD, defended it, no problem. I will never try that with any postgraduate medical college. But the first thing is that they look at you, you are failed.
No.
Yes, now,
No.
That is the problem. So
no,
they will still apply that. That's my worry.
I was trying to avoid argument. What happened was the criteria for graduation are clearly stated. A clearly stated document. It's not yet in public domain. Maybe after that, so everybody will have the opportunity to read it. The criteria for graduation are clearly stated there.
And
so
the teachers have been trained to have a milder mindset.
In fact, there will be limited, like the PhD by research. Nobody will sit down with you and examine you.
Okay.
Nobody will. No. PhD by research is your proposal will be assessed. Is PhD worth? You defend it. You'll be given a go-ahead. Publish minimum number of papers. Submit. It will be assessed and you'll be given a graduation. So no one.
Yeah, we still need to train the assessors because they still have that mindset.
If I can,
the assessors, we have to work on them. That's the truth. All of us examine. We know ourselves.
Okay, Professor.
If I can add a perspective to this, I understand the angle that Professor Garko is coming, and it is very true. I wish the colleges will have maintained, especially the national postgraduate, will have maintained the MD as it is, while partnering with other institutions, like Federal University Azari. We have Federal University of Health Science in Puntua. We can, ABU, Sokoto can partner, National Postgraduate can partner with Azari, can partner with Funtua, so that as you are doing your thesis, you will be awarded the PhD from those institutions. The mindset of examiners and the environment
but don't forget,
is very different.
Don't forget, Doctor, I want to ask you a question.
Sir, I used to go for exam.
I want to ask you a question.
For national and for West Africa. Even in the exam setting, the mindset is different. Once you are in West Africa, there is a particular mindset and the way you need to examine candidate.
Exactly.
Once you are in national, it's also a different mindset. And then once we are doing the master's program and doing defense, it's also a different mind. I don't want us to juggle everything and in the end we can't find a pathway.
Okay, thank you, Vera. I don't want much argument because we have limited time. I think when we are reviewing history, we said that the act that established the National College give it power to award degrees.
Yes.
But we drill and we are awarding diplomas.
Yeah.
We wanted to change that narrative. It's not only National Postgraduate College that is awarding degree. You remember there's NDA?
Yes.
So they award degrees. There's Police Academy. There are other non-conventional university systems that are accredited and approved for degree awarding thing. So I think it's not going to be something new. But let it be given a trial, because what took us into this quagmire, to my understanding, is our response to our enemies in court. What happened to when we are facing in the battlefield. So the way we responded to the challenge is what took us here. As you rightly said, there's nothing special in PhD for somebody that was able to complete the fellowship program. There's nothing special. So
I agree with you. You see, the problem is this. Just like non-medical workers in hospital join forces to form Johesu, it's the same way non-medical doctors in the university and other spheres of life join forces to form against the medical doctor. The NUC is included inside the forces that are fighting us. Unfortunately, some of our colleagues that have not been able to go through the rigors of training or fellowship also are against us. They are also part of it. In fact, they fuel this PhD thing because most of them do PhD at preclinical levels. They are there. Now, we also have this this group of our very senior elders, who I will say is because of dementia, that they also put us into this. They forgot, because they also fuel this thing. Even elder come and said that he had PhD. Then you can't talk, because they'll tell you, even this man say he did PhD. So what will you say? So we had a lot of enemies that joined together, including everybody in the university minus MBBS. All of them are against us.
Okay.
Just know that and have peace.
I have a radical idea for change. And the radical idea I have, one of the strongest weapons that the US had, in the early 90s, Germany was topping in Nobel Prize. And within a short time, Germany started exterminating Jews. And what happened? They immigrated to the US. And then US become the top percentage in having Nobel Prize winners in the world. I think as MDCAN, we need to sit down critically and understand that expansion is very important. We need to even, apart from doing the PhD and integrating it, we need to understand and open up. We have a lot of our colleagues that have MBBS and that have a lot of experience in the field. Some of them have worked in a particular area for a very long time. And that was how we awarded the foundation fellowship to most of the elders. We need to understand and find a way of integrating those our colleagues. Even our colleagues that are having the PhD in basic medical science, we need to be big brothers and find a way to integrate physiologists into internal medicine in some aspect of research, integrate biochemists into chemical pathology and metabolic medicine, endocrinology, integrate anatomists into components of surgery. Once we do that, we all win. The most important qualification that we have is not the fellowship. I'm sorry this is an NDCAN forum, but the most important qualification we have is the MBBS. If you want,
maybe
if
you
you
said
want to
the unifying qualification, not the most
it's
important.
the most important, sir, as the bedrock. If you want to apply to university with MBBS, they will give you lecturer 2, similar to a PhD. So everything we must do is to protect the MBBS. Every other thing is additional.
Okay, thank you very much. So to summarize it, Garko, in summary, what is your view in one sentence? What is the way forward?
Well, my view is that we are winning, because you see, I can assure you in the next 10 years, the number of MBBS fellows with PhD will surpass even the people in the bigger university. I can tell you that.
So way forward, we should
Way
embrace.
forward. No, MDCAN, like he said, we should actually lobby or negotiate or dialogue with our universities of medical sciences to find a way of making the PhD come at an earlier age for the MBBS people.
Okay.
Yes.
What summary of way forward?
So a final summary of way forward. I want to give an advice and I want to give a statement. Inshallah, for those of you that do not understand Arabic, it means by the grace of God. We are not going to fail you, the medical students that are here. This generation will change the pathway of medical education as you know it in Nigeria. By the grace of God, the medical student here, you will not go through the hardship that we went through. We have network of friends across the country and we will implement this change in our generation, biiznillah. Thank you.
So thank you very much.
Even the National College.
Ladies and gentlemen.
Even the National College will change. And the Western College, they will change their mindset.
You want to believe with me that we have judicially used the 30 minutes given to us. And I want to thank the co-panelists for this contribution. Do you want to ask a question? Okay.
Panel discussion about question.
Yes.
No, it's okay. There will be questions. Don't worry.
Yes.
No,
Okay.
Don't
worry.
You can limit to like 3 or 4 questions.
You can only comment.
I know you are biased. I will moderate my question. No.
Mr. President,
But in the
Okay,
so don't worry. They will go and sit down. Kim, go and sit down. Go and sit down. We'll moderate on this thing. Give it to him. Don't worry. So please, in the interest of time, President is drawing our attention to time. So I will select 5. 5. Yes, you. You are president. You won't talk. Huh? You are president now. No, president. 1, 2. So you'll be the last. You are not among the 5. We must protect the presidency. 1, 2, 3, 4, and Samaila. Okay, I'll add you. So I'll start with Samaila.
So please take pen and jot your responses. So please, Samala, don't go.
Thank you very much, Chairman. Surprisingly, I'm not here to take the pathway you thought I was going to take. I think this panel was biased. They should carry myself and I'm able to have joined them so that we can balance the stage. But what I want to say, their conclusion really tempered what I was going to say. It's like asking two different teams to play football. One has two footballs on the pitch with one referee, and they must put the two balls in the net to score a goal, and only one ball with one referee. Yes. The question I'm saying here is that we, from the beginning, the PhD issue, we know as doctors, we know from our heart here, we don't need that thing to be clinician, as they rightly put it. But the way it was introduced, both by NUC with arrogance and by the National College by mistakenly taking that MD, was where the thing went wrong. But I think the way we are taking it, teach the younger ones, let us not shoot it as we were doing before, but we should make it clear to them. Somebody saying that 2026, that thing is rubbish. We should never allow that in this country at any time to say that by this year, we will shut down medical schools. Thank you very much.
Yeah, we'll draw it. Okay, next question. We'll take note.
Thank you very much, the panelists. I think the discussion was quite robust. Thank you, the moderator. I think your explanation on the way forward for the National Postgraduate College is quite commendable. This is what we have been crying for all this while, that this should be incorporated in the training of residency. And that's the only easy way. Any other way will make it difficult for you to achieve. So I think it will help solve this situation. Initially, when we were crying, National Postgraduate went ahead and established MD. Instead of calling it postgraduate, they now PhD, they called it MD. And up to today, the universities have not accepted MD as PhD. So I feel what the new move by the National Postgraduate will help solve this problem. Thank you very much.
So, the one behind you. I've already counted the people now. 6, let's finish. If there's a need for a second round, we'll go. But the ones I identified should finish first.
Thank you very much for the moderators, the panel of discussants. My name is Amadi Christian, MD Chairman, UPTH. I also want to start by noting the bias in the panel is very important. There would have been a balance. There would have been somebody that's purely for clinical fellowship, and then those that have the idea of, and then at the end, we could arrive at a conclusion. However, I want to commend the position, let me call it the new position of the National College. What you presented is the new position of the National College. Because as a consultant, I have said this in our gathering before that I will never advise any resident to do MD program under National College, and I still maintain it tomorrow. We have been arguing that PhD and that fellowship is higher than PhD, and it has not. It doesn't seem to be helping us. And you want to bring another program to tell us, oh, the curriculum is higher than PhD, it is this and that. At the end of the day, they are still telling you it is not PhD. So if you have realized that and you have come back to call it PhD, we thank God for that. If that is implementable, or if it's going to be the way forward, then I can advise my residents to do. I'm already running a PhD, so it's not a problem for me. So I can advise my residents to go through, to do the program, and I'm sure you have more people doing it, because before now, I feel that the MD is a waste of time and money. Then, I also want to commend the idea of having the PhD at the medical school level. Let's do everything possible to actualize it so that this crisis will not continue with generations to come. Thank you.
So the ladies.
Thank you very much, sir. It's like we're moving from darkness to light. I'm so happy. Thank you for the robust discussion. I want to start by talking about my experience. Some time ago during ASCAP in Owerri, 2018, it was a very bitter experience I had then. That I did a study amongst residents about their thoughts about PhD with residency and everything. And actually, a lot of my colleagues came to challenge me at that place. Some of them were like, I'm running down fellowship. What do I mean? So I said, I did a study and I'm reporting and encouraging us to go for residency. For PhD. And I told them, I don't have one myself, so let me be. That was when they let me be. Those were days of maybe denial and hoping that these things will not blow as much as it should blow. It's now really blowing. And I think the way forward, as you all have said, as panelists, is what we should do now and make life better for our colleagues coming behind us. Instead of using agidi, as people will say. I want to ask, sir, National Postgraduate Medical College, we keep hearing that the act that established the college, since it's not a university, since it's not a degree awarding institution, can you actually give PhD? Because we keep telling people and people say go and get MD. It's as if we're running around in a cycle. People say you can get 2 or 3 MDs. It's not equal to PhD. And I keep telling people that I was challenged by Professor Gako in Lagos, September. He said, I can even get 4 PhDs. We have a senior colleague whose children they have to become a doctor, MBBS holder, before any other thing in life. Because he says he believes that once you are a doctor, you can read any other thing. So we can get 4 PhDs. It's not a big deal. It's just that we feel that, why are they harassing us with PhD? But the reality from the history that Professor Muhammad has told us this afternoon is that that was how it was in the beginning. Our senior grandfathers in medicine in Ibadan, they were getting both PhD. Former president of MDCAN was telling me here that that is how it has always been. It was just when they went to Saudi in the days of their exodus, the first one, that we lost it. Can we try and go back now? Can the college award PhD? And I want to also encourage everybody that one way or the other, people are even offering PhD for 2 years in some places now. You just do accountants in my place. I work in Federal Medical Center, Abeokuta. Most of them are PhD holders because they want to be called doctors. They will go to Crescent University, present one small thing, and come back with PhD.
Can you please summarize? So we get the question. Thank you very much.
Encouragement and then question.
Okay,
can the
we'll
college
respond.
award PhD?
Okay, the panelists will respond. The last one is here.
Thank you, Chairman and panelists. Good afternoon, colleague.
I will respond. I will tell them.
I just want to stand with Professor Mohammed. The reason because as a medical student, nursing program, radiographer program used to be 4 years. Now they sat down and review, it's 5 years now. As a student also, optometry and physiotherapy used to be 5 years. Now they are doing 6 years now, so that they become doctor. We sit down and be discussing our own every year in MD committee. And MD member are also member of the MDCM. Normally they are chairman or registrar of MDCM. Normally, since I became medical student, I don't know before I became a medical student. And also they also be NUC, they are MD members of NUC as professors at NUC. So what are we talking about? What do we do with our 1 year in year 1? They sit down and be doing physics, chemistry, biology. Does it make any sense in medicine? To me, it's nothing. So can we, you said about we can use 1 year in research in the program. Can we even look at that first year program, what they do, and bring the research program to the enter exam? As you pass the exam, you go to second year. After second year, you do a research program before fourth year exam. Before Papa Farm. You do that 1 year research program, and then before you finish, I come out with MBBS and PhD. Like we said, if you begin to do a PhD program after MBBS, there is a problem. That's an anomaly. We should find a way around within these 6 years and the scrap chemistry, physics, biology in year 1. It doesn't make sense to me. Because if I don't pass it, I'm not in medical school. But I already passed the A1 in university. And it's something that's teaching me. And the lecturer in science in my school, Amadi is here, in my school, those in chemistry that always after medical students to find them so that they come and sort. So we can scrap that 1 year chemistry program and then find a way to do this research program 1 year after second MB. You can sit and design it, and then when you adopt it, they have no choice. Thank you, sir.
Thank you. Mr. President, you still want to talk?
Good afternoon, everyone. I want to appreciate our discussant. My first question is, where did we get it wrong that we are employed by both university and the hospital at the same time? And where did we get it wrong where we are not adequately compensated for the two jobs we are doing? The next comment, these are my two questions. And what is the way forward? Can unbundling the employment status help us to stop this fight? So that whichever side I want to go, I can determine my fate from the beginning. My comment is that a lot of activities are going on both at the Ministry of Education and with the MDCN concerning some of the comments that have been done by those who have made the comments. In the first stakeholders meeting at the MDCN late last year, there was a submission, and currently MDCN and its board are looking at it. We cannot continue to stay in one place while others are modifying their own to catch up with us, and we are not making enough effort to run fast so that they will not be able to catch up with us. Is it going to be MBBS intercalated PhD? Or even is the MBBS going to even be changed to MD PhD? So that when we get that solution, probably all this issue will not come up. So that they will make it optional. Those who want to be clinicians, right from MBBS, you can decide to do MD and then come out, do your housemanship and continue your online. While those who want MD PhD can add that additional time and chart their way in that direction. Secondly, the Ministry of Education is also doing its own part on this matter. There are always differences. So even you that have done PhD, you know that there are different directions. That is the reason why MD can maintain a position that PhD cannot be compulsory, but optional for those who want to chart their career in the direction they so choose. And that is our position.
Thank you very much, Mr. President.
Thank you very much.
So there are online comments, so take them please, so that we take them together. Can you put on the online, there are online questions. Somebody was asking about...
Somebody said the panelists should be sincere enough to say we need a master's degree, which I do not agree. MBBS is already 2 degrees.
Yeah.
There is master's there, so maybe that is answered.
So we are, luckily enough, me and Garko are in a committee that that quantify the MBBS. We realize that is more than the point needed for a master's.
Yes.
So if you have MBBS entry requirement, you don't need any master's to do a PhD. So that one is sorted out. Can you put on the online comment so that we should be fair to them?
While he does that, can I answer Mr.
Okay,
President?
please go ahead.
Mr. President asked a question, where did we get it wrong? We are employed by hospitals and universities. Now, during Babangida's presidency, he made the system that all teaching hospitals are Institute of Health under universities. CMDs were appointed by vice chancellors. That's how Babangida made it. But there was a disagreement between his Minister of Health, Oliko Erason Kuti, and his Minister of Education, I think Babs Papunwa then, I can't remember very well. So the Health Minister and the Education Minister started the division. He said all teaching hospitals are under health, and the Minister of Education carried universities. So the power of Vice Chancellors appointing CMDs was removed. It moved to Federal Ministry of Health. That was how we found ourselves here.
And it's difficult to, I don't know how we'll solve that. So that's the reason why we're there. Now, the person online also said the MD is an anomaly and it should never be mentioned. Other health professionals are making the doctorate first degrees. There is no longer a bachelor in pharmacy, medical lab, and likely physiotherapy. We are working hard at degrading the MBBS. My answer to this one is very simple. When you are running 100-meter track, if you are busy looking at what the other people are running, you will not win. Face your direction and run. I think the comment made by somebody that we've been sleeping while they were moving, I think is the most appropriate one. We should look at ways to better our program. The first thing is that our MBBS is already 2 degrees. So why don't we just go for graduation MBBS with PhD? MD, PhD. If we can lobby that. That's my own. After that, whatever follows can follow. But we are supposed to have PhD at the end of MBBS.
Okay,
Simple.
thank you very much.
Just to add a context to what Professor Golko mentioned, and I see it, masters should not even be discussed. It is something that should be optional if you wish to gain expertise in an area that you do not have, but not as a career progression for us. Now, when you say MD is an anomaly, I'm against colleagues that feel we should bury and kill the MD. We should not. Now, if you want to win in war, there are strategies. For you to be successful, sometimes you have to confuse your enemy. I'm even advocating, apart from the MD, we should mount Doctor of Science. We should mount Doctor of Public Health. We should mount Clinical PhD. We should mount these programs and get them licensed and get them accredited and open pathway. I'm a Katsina-born son here. I remember when the 16th Waziri, Abubakar Luga, brought the idea of having a university in the state. He established the first private university in this state. It was meant to be an Islamic university then. And then when Umar Yar'Adua, the late governor and late president, wanted to mount the university, there was a tussle. The state government wanted to acquire the Islamic university because at that time they feel that Katsina is not developed enough to have 2 universities, that we shouldn't have 2. But he maintained his ground, and we end up having 2 parallel institutions that are running independently. What is the story now? We have Dusama, we have other institutions, and there are population. Why can't we think of the future? Why can't we think of 100 years to come? Why must we box ourselves to PhD? Why can't we open up? Do MD, do Doctor of Science, do Doctor of Public Health, do PhD. They are all going to be accredited, and they are all going to be important to you one day. Do not kill what you have. Strengthen it. MBBS should be tied to PhD. That's the pathway we are coming. Inshallah, it will be a reality in our lifetime.
Okay, thank you. There's one question that we have not answered, and Victor Maduke was also addressing it. Madam, the National Postgraduate Medical College is empowered by law to award degrees. And the MD is accredited by NUC, and there was a circular by NUC that equated the MD with a PhD. So nothing new on that.
But
I have the circular. I have the circular on that. So, but the position, the way the National College is let me finish now. The way the National College is going, they are going to scrap the MD and then award a PhD. So thank you very much. Let's appreciate the panelists. Now we can continue discussion because we have to protect the neck. The you. Is that not so?
Okay, discussion continues. Chairman has closed it. But somebody said that the National College should not be given to do the master's and the PhD, which I agree with him very well. The university should do it. Thank you.
Thank you very much, our panelists, for taking us through this. And I think, yes, let me quickly do my last thing. But before I now read my vote of thanks for this, let me recall and remember one of the bedrock of why acquisition world over is trained. Our main focus, please, should be the patient, not ourselves. For being in the profession, we have already sacrificed ourselves and dedicated ourselves to the care of the patient world over. So let us reflect on this. I'm not going to give us another lecture. The more we think of earning and having more qualifications as suffix to our names, the more distracted we shall be. And the dictum that says, "Why must you change a winning team?" also stands. Thank you very much. Let me read my vote of thanks. On behalf of the national officers, on behalf of the National Executive Committee, National Officers Committee, and the local organizing committee, the LOC of the MDCAN April NEC meeting tagged Katsina and Dikko 2025, I wish to express our sincere gratitude to all who participated in this event. We extend our deepest appreciation to our special guest of honor, Malam Umar Dikko Radda, PhD, CON, the Executive Governor of Katsina State, for his unwavering support towards the success of this NEC meeting. We also thank the chairman of the occasion, in absentia, Right Honorable Nasiru Yahaya Daura, who is the Speaker of the Katsina State House Assembly, for successfully contributing towards the hosting of this opening ceremony and the NEC. Our gratitude also goes to our special guests, which included Her Excellency Hajia Zulaihat Umar Dikko Radda, First Lady of Katsina State, Honorable Musa Adamu Funtua, who represented His Excellency the Governor of Katsina State and who doubles as the Commissioner for Health, Katsina State, who has been with us for more than 3 hours and added glamour to this occasion. Alhaji Palalu Bawale, Head of Service, Katsina State, Dr. Lawal Aliu Rabe, the Permanent Secretary, Special Duties, who was also with us, Dr. Ahmed Tijana Hamza, Permanent Secretary, Minister of Health, and Professor Jamilu Tukur, the Provost, College of Health Sciences, Umar Musa Yar'Adua University, Katsina, for the support and solidarity towards the success of this NEC. We specially thank our chief host, Dr. Suleiman Bello Muhammad, the Chief Medical Director of the Federal Teaching Hospital, Katsina, for his immense contribution to the success of this NEC meeting, including yesterday night where he hosted us for a sumptuous cocktail. We also appreciate the Executive Secretary, Katsina State Primary Healthcare Development Agency, who is the theme speaker for this event, for his support. Our appreciation also goes to the Minister of FCT, Abuja, and the medical directors of the National Fistula Hospital, FMC Daura, National Eye Care Center, Kaduna, Federal Neuropsychiatric Hospital, Kaduna, and General Hospital, Katsina, for their presence and contribution toward the success of this event. We also thank the management of Atagarawa Specialist Hospital for their support. The president of NMA, Professor Bala Audu, and his entourage were also physically present, and they deserve special appreciation for their continued support to MDCAN. To our guest speaker, Dr. Shamsuddin Yahaya, and also the panel discussants, including Professor Sani Balarabe Garko MNI, Professor Aliu Abdu, and Professor Yahaya Muhammad, we are grateful for your insightful and engaging presentations. We thank our host, the Executive Committee, and members of the MDCAN FTH Katsina, ably led by Dr. Yusuf Musa Rapindadi, who is the chairman of the MDCAN FTH Katsina chapter and doubles as the LOC chairman, for their dedication, hard work, and hospitality. We wish all NEC members, guests, observers, and participants a safe journey back home and look forward to our next gathering in good health and prosperity. Thank you, and may God bless you till we see at the BDM in Enugu in the month of August, September. Thank you very much. So, ladies and gentlemen, with this, we now call the ICT to give us a national anthem and a quick closing prayer by, where is Why is Naziru? Dr. Nazir? Nazir is not here? Okay. We'll call for Godwin Agidzi to come and give us closing prayer, and then we'll call the national anthem. Which one? Which one will come first? Which one come? Prayer. May I crave your indulgence for just some few minutes, less than 5 minutes. We want to give flags to our panelist discussants before the national anthem and closing prayer. So, while they are bringing the flags, we'll request the pleasure of the two chief medical directors in our midst to come forward so that they will present the flags to our panelists. The two chief medical directors here present, please, together with the MD-CAN president. MD-CAN president, sir? Yes, come forward, and you will be helped by the two chief medical directors. They have their names. We start. So we'll start with where is Professor Garko? Yes, sir. We are starting with you. Come forward. The two CMDs, please. Come and flank my president to... No, well, whatever. Yes, you can come here. The cameraman, are you okay there?
Okay, you are connected. Oh.
Fistula Center. No,
The Medical and Dental Consultants Association of Nigeria Appreciation Award presented to Professor Sani Garko, MNI, in recognition of your invaluable contribution as a panelist for the MD-CAN April 2025 Scientific Conference and NEC meeting. This is presented this day, 28th of April 2025. Congratulations, sir.
This an MD-CAN Appreciation Award presented to Professor Aliyu Abdu in recognition of your invaluable contribution as a panelist for the MD-CAN April 2025 Scientific Conference NEC meeting. Your insight on global perspectives on postgraduate medical career development and insight on managing the PhD/fellowship dichotomy in Nigeria have enriched our discussions and enhanced our understanding of career pathways in medicine. Thank you for your expertise and participation. Presented this day, 28th April 2025.
Love can seem so far away. I'll be your shelter in the eye of the storm. Just believe in me when I say you can call my heart your home. Anytime the world.
This award is presented to Professor Yahya Muhammad by the Medical and Dental Consultants Association of Nigeria, MDCAN, in recognition of your invaluable contribution as a panelist for the MDCAN April 2025 Scientific Conference /NEC meeting. Your insights on global perspective on postgraduate medical career development and insight on managing the PhD/fellowship dichotomy in Nigeria have enriched our discussion and enhanced our understanding of career pathways in medicine. Thank you for your expertise and participation. Presented this day, 28th of April 2025.
Thank you very much. While concluding, two important dignitaries, the CMD, the MD of the Fistula Center was here, and as well as the state coordinator of WHO were all present. So you are most welcome. And at this juncture, let me call on Dr. Godwin Agidzi to come and give us a closing prayer.
Thank you, Maestro. Can we please rise for prayer? Silence, please. So can we have 30 seconds silent meditation? O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty, MDCAN may be blessed, Nigeria may be blessed. Amen.
Thank you very much. ICT, National Anthem. Let's read the last part to make it very short. Yes. The last stanza, that's the last part. 1, 2, 3.
Nigeria, we hail thee, our own dear native. Though tried and tongue may differ, in brotherhood we stand. Nigerians home and proud to serve our sovereign motherland.
Our flag
shall be a symbol that truth and justice reign. In peace or battle honored, and this we count as gain. To hand unto
without stain. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty, Nigeria may be blessed. Thank you very much. Any LOC, any housekeeping announcement, LOC? Eh? Okay, how many spots? Lunch is ready. Three spots, left, right, and behind. And we are to reconvene here for the next meeting at what time? Eh? This is 30. No, 30 minutes is too small. That is prayer. So, what?
Working lunch. We are
So, how many?
What's the
What's
time now?
2:08.
10 minutes from 12 minutes from now. People will just see Salah.
When da fara next? Tambaye su ma da nake